Thank you for coming. Thank you to all the members for your attendance throughout this whole process. And thank you everybody else who has an interest in healthcare and where the state is going in healthcare. So first we're going to have Secretary of Science Innovation and President of OSU Health, Dr. Casey Schrum. She will be our first presenter. Dr. Schrum, you are good to go whenever you're ready to start. And just please introduce yourself before you begin.
Well, thank you for the opportunity to be here this morning. And thank you to the committee for all the work that you do. I'm Casey Schrum. I'm the president of the OSU Center for Health Sciences and the dean of the College of Osteopathic Medicine. And I also serve on the governor's cabinet as the Secretary of Science and Innovation. But this morning, I'm going to be talking to you as the president and dean at OSU. So our mission at OSU Medicine is to educate primary care physicians with an emphasis on rural and underserved Oklahoma. So this morning, as I visit with you, I'm going to be focusing more on access from the workforce standpoint. And particularly, I'm going to point out 3 areas that we focus on in the rural physician pipeline, residency training, and Project ECHO in ways that they can help address access issues in the state of Oklahoma. So our rural physician pipeline program really came about in an effort for us through strategic planning to really focus on how do we put doctors in rural Oklahoma as we look at the aging physician population in rural Oklahoma and fewer numbers, the shortage that we have. So we're anticipating more physicians retiring in rural parts of our state. We have to be very purposeful. So we found that there are things that predict where physicians practice mid-career, where they grow up, what we do at the medical school, and where they do their residency training. So for us, we needed to identify the right students to enter into our medical school program. We have a lot of applicants every year, but finding those that identify with our mission, those that we think were more likely to go back to rural Oklahoma. So we created many programs that target students in rural Oklahoma, like our Blue Coat to White Coat program, or students that are in the FFA, are the type of students that we target, and we try to engage through outreach programs that we do across the state as well as at our campus. We believe those are students that have an affinity to a lifestyle in rural Oklahoma and understand serving, but we also recognize that compared to their urban peers, they're less likely to be thinking about a career in medicine in high school. So it's important even in middle school to begin reaching those students. In our medical school curriculum, we've been very focused on not just training our medical students in Tulsa. We know if we get medical students, we keep them there for 7 years. They're not likely to go too far from Tulsa when they graduate. So throughout our curriculum, we make sure that our students are connected to physicians who are practicing in rural Oklahoma, that they have mentors, that we are teaching them about the challenges that our state faces in rural areas, and that they have lots of opportunities to spend time during their clinical clerkships in rural areas of our state. Rural residencies are important. Residency training is the capstone of medical education. It's where doctors finish their career. And our data suggests that 80% of our residents will stay within a 100-mile radius of where they train. So making sure that we are training doctors across our state is important. Since 2008, OSU has grown our residency programs, residency slots by 118. Many of those are across the state and in rural areas. Those are primary care programs that we have placed across the state, and we have done that in various ways. As we grew our programs, we had to be creative with how we funded those. And I think it's important, this is an important point to talk about in residency programs, because in 1997, the federal government passed a Balanced Budget Act, and that had an impact on residency programs. It froze funding to hospitals that had residency programs in place at that time to the number of residents that are in that facility, even today. So growth in residency programs in hospitals that had residents in 1997 is at the same amount. So any growth that we've seen has been because hospitals have invested in it, or there are programs that were created in new hospitals or through new funding mechanisms. I'm happy to say in Oklahoma that we have done a good job, and we are fortunate that we have enough residency slots for our medical students when they graduate. But we have an opportunity, because of what's going on and the trend nationally, is that as there was a need for more doctors, there was an increase in the number of medical students, but the number of residency programs did not grow in the same proportion. So we're approaching, probably in the next year, where there will be more medical school graduates than residency slots in the United States, which creates an opportunity for Oklahoma. We can become importers of physicians if we invest in growing residency slots, because those doctors will be looking for a place to train. And while they're here, they will be taking care of Oklahomans, and we have an opportunity, we have a better chance of keeping them here in our state. Now, I will say that in Oklahoma, if our students go to medical school in Oklahoma and they do a residency program in Oklahoma, we have one of the highest retention rate of physicians in the United States, according to the AAMC. So we do a very good job of retaining the physicians that we have and that we're training. We have to be mindful of how we train them to ensure that they're going to the right places, and we want to get the right students. But we have an opportunity to expand, and there are many different funding sources you can see on the screen. Some of those are federal and some of those are state, all of which we have utilized as we expanded those 118 programs. But what's true about funding of residency programs is it's not a one-size-fits-all. Each of those funding sources are very specific about what type of program or what type of hospital are eligible for those funds. But I do believe that as we expand, we have opportunity to expand residency slots at both teaching hospitals. That's important. That's where we train our specialists, our medical specialists, and our surgical specialists. And although we focus on primary care, there is a need for both in our state. But also in rural hospitals and focusing on expanding rural residencies as well. Because again, residents tend to stay where they train, and in our rural programs we've seen that sometimes the more rural the program, the higher percentage stay within that area. So Project ECHO, I know that some of you have heard about Project ECHO. It is a program that really focuses on physicians who are already in practice. They're out in the communities training, and or taking care of patients. And it is a continuous education, an active, lifelong learning process. And it utilizes a video conferencing system. And the purpose of it really is to be able to take best practices and knowledge that are at the university with a team of specialists and transfer that to physicians who are practicing in the community. Project ECHO was created at the University of New Mexico by a physician named Dr. Aurora, who was a liver specialist. And in New Mexico, they have a high incidence of hepatitis C. It's easily identified, treatable, but if it's not treated, it's terminal. It turns into liver cancer. Dr. Aurora was one of few specialists in the state that was taking care of hepatitis C patients. And because the physicians in the rural communities didn't feel comfortable taking care of those patients. They were all being referred into specialists. Well, what happened was, what we see a lot of times here in many specialties is that the wait time was very long. It cost the state a lot for patients to travel to see those doctors. Many times they put off seeing a doctor because they didn't want to take off work or they didn't have the money to drive. And so many of the patients he was seeing, who he should be able to treat, he was delivering bad news that they had cancer and that they were going to die. That wasn't acceptable to him, and so he decided that what he needed to do was to be able to connect with these physicians across the state who were interested in treating hepatitis C, but didn't feel confident or supported in that role, and educate them like we learn in residency. So day one of residency, as a pediatrician, I began seeing pediatric patients. And every patient I saw, I went back and I talked to the attending, and they would give me feedback on my diagnosis or my treatment. And through that process over 3 years, I became an expert because I learned from my patients and I learned from my co-residents' patients. Project ECHO is the same way. It creates a network of physicians that once a week gather at noon. They get a 20-minute lecture from a team of specialists. And then they can present patients to this team of specialists, and so can their colleagues that are on, and they begin to learn from their patients, and they learn from their colleagues' patients. And so for Dr. Aurora, he began to see a decrease in his wait time, but what was most important to him was not just that people were getting care. He wanted to see if they were getting quality care. So he did a study, and it was actually published in the New England Journal of Medicine. And what they found in this study is that after a year of participation in Project ECHO, those primary care physicians their patients had higher cure rates than those patients who were being seen by a specialist at an urban hospital, and slightly better than patients that were being seen by a team of experts at the university, because those doctors had the knowledge, but they were in the community, they had a trusted relationship with the patient, they understood the family dynamics, they understood what those patients were going through. So patients got better care. His wait times went down, and he started seeing the patients he needed to see. They also found that the doctors who were participating at the beginning of Project ECHO said that they were burnt out. They felt isolated in their rural practices, which is what we see a lot of times here. But after a year, they reported significant increases in job satisfaction because they felt like they were connected to a network, they had colleagues, and they could see that they were making a difference. So Project ECHO is a way to expand capacity in various specialty areas so that patients across the state can get the right care at the right time in the right place. So at OSU, these are the various ECHO lines that we run. We also run some ECHO lines in education, and we've had a lot of conversations. So across the United States, Project ECHO is now not only used in medicine, but education, in workforce development, in many, many different areas. The way that we have funded Project ECHO is we looked at what are some of the greatest public health needs and tried to match those up with private foundations that had an interest in that particular area. So our ECHO lines are supported by private dollars. Now in Missouri, and there are some challenges to that in that there are ECHO lines that are needed, but foundations are not interested in that area. In Missouri, Missouri funds through appropriations Project ECHO, and they have a state focus on many, many different areas. I think that's important because as we think about health and overall health, And I'm sure you as a committee have heard from many people about different aspects of access, health outcomes. You know the statistics. I didn't bring them today. It's important to recognize that about 20% of our health is in that clinical care segment. Our health outcomes are affected by multiple factors, many socioeconomic factors. And through the utilization of Project ECHO, you have the ability to focus and bring best practices and knowledge to the entire state on matters like education, making sure that all teachers have the same resources, the same knowledge in STEM, in many areas of education, workforce development, economic development, that communities can have access to experts and use that knowledge in their community to make sure that we are addressing all matters that affect health so that we can begin to have great health outcomes in our state. So I'm going to finish with a project that I'm proud of, but I think that all Oklahomans can be proud of this because it's receiving significant national attention because of the historic nature of our partner, of Oklahoma State University's partnership with the Cherokee Nation. We have created the first tribally affiliated medical school in the United States. It is a model for addressing underserved and rural health. It is an opportunity to train students and future physicians all the way from the first day of medical school to the end of residency program in a rural location. But I think what's important to think about with this medical school, because it's a beautiful building, 50 new students every year will be going to that school. But if we think about the location of that school, it sits less than 25 miles from Stillwell, Oklahoma, with a life expectancy of 56.3 years, which is 22.5 years less than the United States average, but it's on par with Uganda and Mozambique, which is really not acceptable here in Oklahoma. That medical school will provide the opportunity for those individuals to seek care, but also to change future generations, because if any of those students or any of those kids end up going to that medical school, it changes their families' lives for generations. So thank you for the opportunity to be here with you today, and I'm happy to answer any questions that you might have on anything.
Thank you, Dr. Shrum, for that. Senator Hast has a question.
Thank you, Mr. Chairman, and thank you, Dr. Shrum, not only for your presentation, but also all the great things you're doing for this state. First question is, you were showing the buckets of funding and so forth, funding sources for OSU. TSET was one of them. Was that, the funding you got from TSET, was that a one-time funding, or is that ongoing?
Yeah, so that was funding as a part of when we created rural residency programs. So we targeted rural hospitals that did not have any residents in them. And so as you start those programs, they have 5 years to get up to the full number of residents that they will receive federal dollars for. But what we learned from rural hospitals is their operating margins were so narrow that they couldn't afford that time period between starting a residency program, paying those residents, to the time that they started receiving federal dollars to support those. So we went and we asked TSET for one-time funding that would provide gap funding for those residency programs until the federal dollars kicked in.
Follow up.
And what was the amount of that funding?
It was $3 million, and then most recently we received funding from TSET for a potential program in Enid.
Follow up.
Thank you, Mr. Chairman. Switching gears just a little bit, and I'm going to pull a little bit off of your pediatric background versus some of the stuff that you talked about. One of the things that gets talked about within Oklahoma, and let me back up. Obviously, with this committee, outcomes is something that's very, very important. And for me personally, that's one of the things we've got to be focused on. So some of the conversation we've had is more dealing with some of the symptoms of that, but how do we address these outcomes? So one of the things gets talked about is the number of children that we have in the state that are on free and reduced lunch programs. But then at the same time, we talk about high obesity rates in the state for our children. How does that come into play?
Right. So as, you know, that last slide addressed the fact that, you know, there are many factors that play into our health. And we certainly do have a very high rate of obesity in our young population, which means that, you know, that is a factor that predisposes them to, you know, some very serious health outcomes as they get older. But when you look at those social determinants of health, poverty is an issue, and, you know, having higher rates of obesity, some of that is the fact that there's not much, you know, in many places there are what we call, you know, food deserts where there aren't grocery stores, there aren't access to healthy foods. And so many times it is also cheaper. I always tell this story. I have 6 children, and my oldest son, I had him take the kids to an event, and I gave him some money and said, take the kids to eat and afterwards. And so they came home, and they'd had a great time, and the younger kids were telling me, yeah, we went through McDonald's. Colton got us a big bag of cheeseburgers, like 20 of them. And I said, well, that's interesting. So I asked my son, I said, you know, why did you go there? He was like, well, Mom, I could spend $20. They got a lot of cheeseburgers, and I have a lot of change left. And I said, well, I need the change, first of all. But I think that, you know, is something that I don't usually have to think about is how I'm going to feed that many children with a limited budget. You can honestly feed those kids cheaper at a fast food restaurant when you're on a tight budget, when you don't have access to fruits and vegetables or good foods. So I think, you know, there's also an opportunity here, you know, when I talk about addressing education, addressing workforce development through ECHO, there's also an opportunity to address school lunch programs, community lunch programs. It's all about having the knowledge for people to make the best decisions, and it's really hard to get that out there at times.
Follow up.
Okay, thank you, Mr. Chairman. And one last thought tied in with that, you know, and you're talking about economically challenged situations and so forth, and so SNAP comes into play in that equation. Within the SNAP program, are there anything tied to, you know, it's got nutrition as part of its name, but is there, how you use that, is it tied to any type of nutrition, or can you just basically buy, you know, go in and buy candy if that's what you want?
Yeah, you can, you know, you can purchase candy with SNAP. I mean, there are several things that, you know, there are a lot of things that are approved, and they're not restricted on, as long as it's approved, they can purchase that. I think there are opportunities for reform within that program to provide education and, you know, maybe to provide opportunities, again, to, you know, buy foods in a healthy manner. But again, there's those struggles of the food deserts and lack of access that we have to address.
Representative Stark.
Thank you, Mr. Chair. Thank you also for being here today. I have kind of a broader question about how do the residency programs work? I mean, I know how are they funded, and what does it mean to expand that? You referred to federal dollars. Are they all federal dollars? How does, an overview of that, if you can.
Right. So I don't know that I can give you the full complex rundown of all of residency funding. It is very complex, and as I said, it's really not a one-size-fits-all. There's really two different ways for federal funding. Through CMS, Centers for Medicare and Medicaid. That funding was capped for hospitals that already have residents in 1997, so there's no opportunity for federal dollars there to increase. New hospitals that have never had a resident are eligible, which is where we did the partnership to help those hospitals with state dollars 1 year, the state appropriated dollars, and then there were no more dollars. Then we went to TSET to finish out that program. And then those hospitals were able to get on CMS, which that's ongoing funding, but they will never be able to expand with federal dollars because they're capped now. There is a program through Health and Human Services, which is teaching health center programs, which those are community-based residency programs, which are great. They're not tied to a hospital because really it is very complex what hospitals, even if a hospital has never had a residency program, it has to make sense for them for various perspectives. So teaching health center programs are great. You can put them in a community, those fund residents. The challenge with that is that that program many times has not had continuous funding. So they started the programs and then they would say, we're not going to fund past this date. So then you have residents in training. You have to figure out how to fund those residencies. It also is intermittent. So OSU has 5 teaching health center programs that we run, and they're great programs for primary care. But the challenge is they're not always available. So as you really look, there are opportunities that are kind of hit and miss to expand from the federal level. At the teaching hospitals, that really is going to have to be a state-based solution because we're both capped on what we can do and what we've been able to grow, and the places that are already educating residents. So it really is making a decision that we want to do that and then exploring all those options really on a one-by-one basis about how you do those. And being aggressive in going after those federal grants when they're available. And there are a few other programs that are available if you're working with a tribe. The VA hospital is a funding opportunity. They have their own pot of money, but that has to work too. So there are various, but we also have to really be creative too in the way we think about funding them.
Follow up.
Thank you. Do you have a ballpark figure of what it takes, like for one residency to expand one,
Right.
to just add one additional program?
Yeah. So our right now, I can tell you what we get for our community-based programs is about $80,000 per resident, and that's per resident per year going forward, and that's a community-based program in primary care.
Senator Hicks.
Thank you, Mr. Chair. Thank you, Dr. Shrum, for being here today. So to kind of build on that last line of questioning, I've been doing quite a bit of research on the GME slots, and based on what I've discovered, it seems that states in that top 10 category for health outcomes have about 32 slots per 1,000 residents, and Oklahoma is currently at 17. Mm-hmm. I mean, would you agree that if we were able to expand, that we would start to see some better health outcomes for our residents?
Yes. I mean, as you look at those states that have better health outcomes, they're also the states that have a stronger physician workforce. And in order to do that, it is through residency programs. And so, yes, I agree.
Follow up.
Thank you. So I guess to maybe even play devil's advocate here, Kansas and Missouri currently have like a certification process, so to speak, for their grad students who don't match with a residency program. It allows them to go into general medicine. Would you share your thoughts on that and whether or not you see that as a potential competitor or threat to what we're able to accomplish in Oklahoma if we don't also look at that area?
Yeah. Well, first I would say that I think it's an unfortunate situation for a medical student who's put in that many years and has dedicated their career to not be able to find postgraduate training which would allow them to practice medicine. After graduation from medical school, I think residency is a great opportunity to continue to learn and gain autonomy and become confident in your field of study. And so while I think it's great to provide those students with an opportunity so that they're not sitting on the sidelines with a very expensive education that they can't do anything with, I don't think it's the optimal solution. I think the optimal solution is to have the highest quality medical workforce that we can possibly have in the state of Oklahoma so that my family and your family, when they go in to see someone, we know that they're going to get great care. So I think that it is a solution for those students. I don't think it's the best solution going forward. I think I don't think any medical student really loves that option. If there's residency slots available for them, they will happily go into them. So I hope that we don't get into that situation, which, like I said, I'm very pleased that today in Oklahoma, our medical students, if they want to stay here in the state, there's enough residency slots for them. But I hope we don't get into that situation with our medical school graduates. That would really be doing everyone a disservice.
Follow up?
So to go one step further, do you feel like there would be some opportunity, I guess, here, in that kind of space about, general physicians in conjunction or partnership with, Project ECHO and helping expand and broaden that reach of those specialists, to maybe underserved areas that might, initially grant us further access for healthcare in rural communities?
Mm-hmm. I do think that there's an opportunity for I really believe that there's an opportunity for all providers to take care of patients. I think that there's opportunities there. I don't know that we don't currently see that anyone filling those shortage needs to date in those areas. So unless we have programs that specifically are tied to a geographic area that's a shortage, and we have the supervision set up in a way that makes sense, that it will actually have the outcome, the desired outcome, I think, that people are looking for.
Dr. Sherman, appreciate you being here. We have more people in the queue, but it's my turn. So, but I appreciate you doing that schedule dance that we did right here at the last day, and I appreciate your flexibility and moving to an earlier spot. I also appreciate your service to the state. Appreciate that, as if you're not busy enough already. I have two really unrelated questions, but first, could we have not talked about in this committee, this work group, we haven't talked about Hep C. Will you talk about, the issue with Hep C in Oklahoma? Can you kind of characterize that? One of your doctors, when I was at the Project ECHO thing, he was talking to me about Hep C, and it was information I didn't know. So if you could just kind of give us a really high-level view of what's going on in Hep C in Oklahoma.
Yeah, so we do have, a high incidence of hepatitis C. It's a blood-borne illness, so that's how you can contract hepatitis C. What we currently have now is Project Echo, in collaboration, and the Cherokee Nation specifically focuses on it, and they're working very hard to eradicate hepatitis C, and that is very possible through the work that we do in training physicians, primary care physicians, to take care of hepatitis C. It is very possible. And again, when we can treat a disease early on, when we recognize it, because it is a reportable disease, which means if you test positive for it, we know that you have it. If we aren't connecting those individuals with services or care, or giving them care where they're at, the cost of that health care just continues as they become more and more ill. So we are working in this state through Project Echo, through our university centers, with the tribes, to focus on eradicating hepatitis C here in our state.
Thank you for that. My second question has to deal with workforce development. And I really appreciate the rural focus that OSU has taken on workforce development. If you had your way and there were no impediments and no obstacles in the way, what would be policy ideas for this group? We have Physicians Manpower Training Commission trying to help on that front of workforce development, getting doctors here. What would you do? What would you do if you could just do whatever you wanted?
Mm-hmm. Well, first, I would actually look across the state where we have workforce needs and put residency programs there and have them funded on an ongoing basis. Currently we have to look at where those are, and not necessarily in the greatest need, but where we can make them work. So as you could see, our map sometimes isn't covering the entire state because it doesn't work, although those communities desperately need residency programs. So I think providing funding, one, for residency programs, placing them where we think they need them. Secondly, providing more funding to our teaching hospitals so that we can expand residency programs there. Because I think the thing that we have to remember is we can train more residents and specialists in our teaching hospitals, but we can't forget the entire state. Providing some incentive areas. I think there's been some work on trying to provide tax incentive, but loan forgiveness, aggressive loan forgiveness programs for targeted rural areas is very effective. I think it works, especially in conjunction when you're looking at what I talked about as areas that are predictable, things that predict where someone will practice mid-career. If you can, find a physician that's coming through a program like that and provide loan forgiveness in that area, they're probably not going to leave. I mean, what you don't want is to provide loan forgiveness, people live there, and then they leave, because then you have fragmented care and you're back to step one. I think providing scholarships, also in medical school, which is something, or some tuition waivers, is something that, I've worked on throughout my career, in raising tuition, raising scholarships for students that are coming from 4-H and FFA into our medical school. Those would also be important for us to get an adequate workforce. I'm going to go a little bit back, I think, because this is something that's really important that I think sometimes we forget about. But, we have to have kids, students that are educated and prepared to enter into college and ready to go into medical school. And, we do a lot of outreach programs, and so I think, having that strong STEM component in our high schools and preparing those students and having a way to identify those students and get them engaged early is important, and having funding for that, it's something that we have done. But, you can only stretch a budget, and we're very fortunate that, honestly, a lot of Oklahomans have given to those programs to support that. But I think that's the key to having a strong workforce. But I would go back to just saying expanding those residency programs are really important, because we have an opportunity then to bring physicians to the state to train and to keep them here, especially, if we can give that quality of life that they want here for their families, the education system that they want. It is a real opportunity, I think, for us to see that in the future and to capture that moment.
Senator Coleman.
Yeah, as I think, as I was saying, this kind of national trend, I mean, our students can stay in Oklahoma if they want to, and we have those residency slots. There are a lot, there's going to be increasing numbers of students who aren't matching across, when they graduate, needing a residency program. So there will be ample ways to fill those residency programs. From the perspective of, expanding the medical schools, class sizes, I think the most prudent thing to do at this point is to expand the residency programs.
Follow up.
Yes, yes. And it is very competitive for students in what, areas and fields they go into. Unfortunately, in medicine right now, primary care physicians work long hours, see a lot of patients, they're the front lines, and, the reimbursement rates aren't as good as what they can see as a specialist in a practice where they somewhat can control their lifestyle a little bit better. That's part of the challenge with urban versus rural. And some of the reasons why we have to have programs that support physicians that are practicing in those areas and things that improve their job satisfaction, because, it's a difficult job. And when you live in a community, I practiced in Muskogee when I came out, and you see a lot of people, and you go to the hospital, you see patients. For those who take care of adults, sometimes they go to the nursing homes, and they're on 24/7, and sometimes without a partner, they get very little rest. So, really focusing on the rewards and trying to find ways to recruit more doctors in, because if you're one of three, that's better than one in a rural community.
Follow up.
Yeah, usually it would be sometimes there's there can be a tie to Oklahoma. So somebody who has family in Oklahoma wants to come back to Oklahoma. There's a particular program that they want to go in, and they've looked and either they spent time here as a medical student and enjoyed their time, liked the program, felt like they fit. That's a draw. And in general, more and more what we're seeing is with fewer and fewer residency, more students coming out with a fixed number of residency slots, they're really looking to states where they think they have a really good chance of getting into those programs.
Representative Rowe.
Thank you, Mr. Chair. I want to back up for just a minute and talk about Hep C for a minute. I actually have an interim study related to Hep C, but one of my frustrations I'm a nurse practitioner, and I've had patients with hepatitis C that I've referred for treatment. And one of the problems that I have run into is some of these people are still actively using IV drugs, which is probably, in my opinion, the ones that we need to be focusing on because they're the ones that's spreading a lot of the disease. How has Dr. Mara and his group, and I was at Project ECHO, and I think that was a wonderful presentation related to the hepatitis, but how do they overcome the insurance companies and the clinic's refusal to treat it because these people are still actively using drugs?
I probably can't answer that question for you because I don't see those patients, so I don't know. I know within, of course, the Cherokee Nation, they care for a lot of their citizens, so that's not an issue for them as much as it is for others. I don't know. Dr. Stevens, do you have any? Okay, yeah, we don't know his protocol and how he addresses that. I'm sorry.
And our last questions come from Senator David.
Thank you, Mr. Chairman. Last but not least, Dr. Shrum, thank you so much for being here. I just want to point out that Dr. Shrum is my constituent. She's doing an amazing job in my area, and I'm very pleased that she lives in my district. Dr. Shrum, you know, for many years, Oklahoma exported our medical students to Missouri. I have many friends who went to medical school and did their residency in Springfield, Missouri, and stayed in Springfield, Missouri. Mm-hmm. So I want to point out, before I get to my question, that your Blue Coats to White program has made a huge difference in rural Oklahoma, where many of our kids in rural Oklahoma thought that they should go to vet school. And we have plenty of veterinarians. And to the point where we were telling our kids, you cannot make a living at this. Don't do it. You know, you've got to look at another field. And I personally know several of my young people in our district where we live who have changed their career paths and are now going to medical school. But what I really want to touch on today is what's going on in Tahlequah. Because according to our health department, nothing's going on in Tahlequah because they don't count statistics when it comes to Indian health. They just ignore them. So I appreciate the fact that what you guys are doing in what the job you're doing with the tribe with the Cherokee tribe in Tahlequah is much needed. It's fantastic. It's going to make a huge difference. What I was wondering is if you could touch a little bit on how that funding will work with the state going into this partnership with the tribe. Will we be able to get more federal funding in for those residency slots and for the medical school?
Yes. So I think the answer to that is yes, we are hopeful that because of that unique partnership that allows us to have different opportunities from a federal level. Certainly, we hope that we can continue to work with the Cherokee Nation to provide scholarship opportunities for students that are working there or going to school there and continue to work within the tribal nations. I didn't say, one of the things I did not say when I was talking is we also have residency programs with the Cherokees, the Choctaws, and the Chickasaws. So there is opportunities for certain pots of money because of those relationships in residency programs. But yes, it does allow us to go together to look for different federal dollars than what we could as the state alone in a state-funded program.
Thank you. That's it.
Well, Dr. Shrum, you're off the hot seat. Thank you very much for coming and talking to us today about workforce development and what's going on at OSU. We appreciate your time. We will take a 10-minute break, and then we will reconvene. We're going to do things a little bit differently. We usually have a speaker and then questions. We're going to let the next two speakers go in succession, and we'll see where we are at that point. If we need to take another break, we will. And then we will have opportunities to ask questions of both of them at the same time, since they're both, they're talking about first rural and then urban healthcare. So first we have Duncan Regional Hospital's President and CEO, Jay Johnson, to talk to us. He is a friend of mine. I invited him because he does a wonderful job and move away from that mic that's popping. He does a wonderful job of talking about rural health care because he's on the front lines. He's also the chairman of the Oklahoma Hospital Association. Mr. Johnson, go ahead and please start and introduce yourself.
Thank you, Representative McIntyre. It's a real honor to be asked to speak to you all today, an honor to have this opportunity to tell you a little bit about our hospital and about what's happening in rural Oklahoma. Before I do that, I want to tell you a little bit about me, so you understand some of my frame of reference and where it is that I'm coming from. I was born and raised in Lawton, so I've been here a lifelong Oklahoma, and I spent 5 years outside of our state. I've spent my career in 3 hospitals primarily, 9 years at Stillwater Medical Center in Stillwater, 5 years at Mercy Hospital in Ardmore, and now 9 years I've been the CEO at Duncan Regional Hospital. So I want you to know that what I'm going to share with you has really been on my heart a long time. I mean, I believe in what we do as a hospital in the healthcare industry. I don't believe we're perfect, and I believe there's opportunities for us to get better, and I believe there's opportunities for us to work with the legislature to do more. But I also want to share with you specifically today really where we are in rural Oklahoma. And so based on my last 3 places I've been and lived, so growing up in Lawton and living in 3 of probably the more prominent rural communities in our state, I think I have a really good perspective on where we are in Oklahoma and where we are with rural. Most of you probably aren't familiar with Duncan Regional Hospital, so I want to give you a little bit of background. I call ourselves a small rural system because in 2017, the hospital in Waurika wasn't doing well, and we had the opportunity to work with them and begin management of their hospital. It's what's known as a critical access hospital in the industry. So we're a private, not-for-profit hospital. We're not a public trust. We have almost 1,200 employees and about $138 million in annual net revenue. One of the things that we're proud of that we're doing is we have clinics in 9 communities, what we call, if you've been on Highway 81 in Oklahoma, the 81 corridor. Our market's really from Chickasha at I-44 south to the Red River. And we have clinics in 9 of those rural communities. Those include in Jefferson County, Ryan and Ringling and Waurika. In Cotton County, we're in Walters. And in Stevens County, we're in Duncan, Comanche, Velma, Marlow. And then in Grady County, we have an OB clinic in Chickasha that we work with the hospital in Chickasha. So we lead those 2 hospitals, one in Duncan and the one in Waurika, to really develop a little system of care down there. One of the things that's unique that we are proud of is we're the only provider of health care in both Jefferson and Cotton County. And those are 2 of the smallest counties in our state. And I think what you're going to hear, you heard from Dr. Shrum, and you'll hear from me, and I'm sure you'll hear from Chuck, is that access is probably our primary issue, access to health care, if we want to improve the lives and improve the health of Oklahomans. And I would like to say, there's not many people that are better than Dr. Shrum doing the job that she's doing in our state right now. So I told her I wanted to leap up and yell amen several times during her talk, but she didn't ask for one, so I didn't give it. So hospitals are unique, and I think there are things that not everyone understands about hospitals because we often get talked and get spoken about in the hospitals need to compete like everybody else. And I don't necessarily disagree with that, but I don't think everyone understands that hospitals have some distinct characteristics that many people that we compete against don't have. Back in the 80s, the late 80s, President Reagan signed into law a law called the Emergency Medical Treatment and Labor Act. And that required hospitals to treat everyone that comes in their emergency department, regardless of ability to pay, for life and limb circumstances. And another misnomer that's out there because of that act is that all people have access to health care. I guess it is true that all people do have access to emergency treatment if they're in a life or limb situation. But much of what we talk about on the policy side, and you all talk about in debate, is the need and the ability to manage people's care. How do you keep someone healthier? How do you provide them access to people that can help them stay healthy? Chronic disease management does not happen in emergency departments. Our emergency departments are also available 24/7, all the time. That is an incredible state of readiness. If you can imagine any of you with your businesses, if they were always available and ready to treat anything that walked in the door at a moment's notice. That is not inexpensive. That 24/7 readiness comes at a price. Dr. Schrum spoke a little bit about that in her question and answers, about the availability of some of these critical resources, especially our doctors and our specialists. One of our biggest challenges in Duncan is we are a level 3 trauma center, and our board takes a lot of pride in that, and they want me to work to ensure that we keep that. So what's that mean? Level 3 trauma centers are really our front line of safety net for our state. That means we provide 24/7 access to general surgery and orthopedic surgery. So if you walk in our ER, we can have a doctor there within 20 minutes that can treat you if our board-certified emergency medicine doctor believes that that's necessary. Most communities in our state do not have that access, and it is expensive, and that's where that 24/7 readiness comes from. We also do a lot on emergency preparedness, and this kind of goes unseen many times because the work we do drills, and if you come in a hospital, you might hear the alarms go off, and we're practicing mass casualties, things like school bus incidents, tornadoes, droughts. All those things can have implications for communities. Even Ebola. How does a hospital like ours manage the situation if an Ebola patient should show at our ER? We have to train our people, teach our people how to stay safe in those environments, and how to keep the entire organization safe in that time. It's not an easy task. We buy supplies that expire because we have to. We have to have a surplus of that equipment. So these things are expensive. We also have a pretty big uncompensated care. I'll show you some of those slides here in a few minutes. And then in the hospital industry at large, the cost for tertiary and quaternary care is expensive. So what is tertiary and quaternary care? Tertiary care, you get into a lot of your neurosurgery and your cardiovascular surgical specialties, but quaternary care, you really get into burn centers, transplant centers, and those kinds of things. You notice there's not any entrepreneurs trying to compete for that work. It's expensive work, and hospitals, our industry as a whole, is there to provide it. So my point for this slide really is that business competitors aren't always bound by the same rules that we have. We have an additional cost load that's more expensive often. And then rural hospitals are even more unique. The interesting thing about rural is, and the difference between a rural hospital and an urban hospital, is we own the issues of our community. And because there's primarily 2 urban areas in Oklahoma City and Tulsa, as you know. And within communities like Duncan, whatever community problems exist, we're going to be dealing with it at our hospital on some level. We can't escape it. There's strategies within healthcare that allow organizations, businesses, to find places that are more profitable, that are more affluent, that have higher mixes of commercial payers. Of course we want commercial payers, and of course we would like to do some of those things as well. However, in rural, healthcare is also generated by the amount of people that you serve. We take care of everybody, regardless of what payer mix they bring to the table. The problems of our community are part of what our strategy is, to take care of our community. Our mission at Duncan Regional is to provide compassionate and exceptional health care while improving our community's health. And I would say not all hospitals have that last clause of our mission statement, but our board finds it really important. It's a public health mission. And it aligns much with what you all do in this building to try to create healthier communities, and we take that seriously also. The more rural you get, the less volume there is to support services. And so low volume and lower populations can contribute to hospitals not being as successful as those that have the opportunity to have greater volumes. Rural hospitals have a higher dependence upon Medicare and Medicaid. I'd call those our government programs. And it's typically, when you're managing the business side of a hospital, you're really seeking to get commercial payers to your hospital. Commercial payers are Blue Cross, are Aetna's, Cigna's, United's. They pay exponentially more, and that's how hospitals make a profit. Because on every government payer, we don't make a profit. At our hospital, whether we're taking a Medicare or Medicaid patient, our expenses are greater than what we will get paid. It's the hidden tax, and I'll show you a slide in a moment that shows that. But the hidden tax is that all of us that have commercial insurance pay exponentially more because our government programs don't pay enough for us to break even on that care. And in rural, as Medicare, Medicaid populations get greater, our rural populations are aging more than our urban populations. That problem grows more. There's a higher percentage of uncompensated care in the rural areas than urban. Rural is less expensive to live. But one of the advantages in rural is there are government programs that are designed to help some of these low volume places, particularly the Critical Access Hospital Program and the Rural Health Clinic Program. There are some payment incentives if you participate in those programs and you qualify that can help you keep clinics open in some of those very rural areas like I mentioned that we have at our hospital. This is a slide that we update at the Oklahoma Hospital Association annually. Our most recent data goes through 2017. And it gets brought up at a board meeting probably at least every 6 months to show how our hospitals are doing. And it's really quite dramatic. And I don't think most people are aware of it. But hospital margins have been declining from a high of 6% average for urban in 2006 down to just barely ahead of break even from operations in 2017. And if you look at the plight of rural's even worse. On average, Oklahoma rural hospitals are not making a positive profit margin. And I think you all have seen that. We've all seen that in the headlines in the paper. One thing I'd like to point out, I think is unique, is if you look at 2014, rural took an even greater dip. 2014 is when the cuts from the Affordable Care Act or Obamacare went into place. And I think many people lose sight of this too. That act, when it went into law, was designed for Medicare to be able to start getting their costs under control by reducing how much the payments were for hospitals. But we were supposed to get Medicaid expanded, and that was supposed to lower the burden of the uninsured in all of our hospitals. So as Oklahoma, with one of 14 states that haven't expanded Medicaid or haven't accepted federal funds, that's what's creating the fragility within our hospital system within our state. So what's the impact of that change in our operating margins that we were just looking at? 6 hospitals have closed, 8 have declared bankruptcy since 2016. That's pretty dramatic. Some of you probably represent some of these people or some of these areas. You know, that comment there at the top that was published in January of 18 from Healthcare Finance, hospitals in states that expanded Medicaid were 84% less likely to close than hospitals in non-expansion states. We probably would have saved some of those hospitals had we done that. I've talked about some of these things. Of course, the cuts from the Affordable Care Act I just mentioned. We have had state budget cuts. I would like to thank all of you for the bump that we received in rates last year, but we're still below where we were in 2010. So as I discussed, the continued cuts without any reductions in the uninsured. Small communities, low volumes, and not eligible for critical access. That statement is to say, of those 6 hospitals that closed, none of them were critical access hospitals. And in many locations, the critical access hospitals are smaller than those hospitals that closed. And so we have 39 critical access hospitals throughout Oklahoma. And there's probably opportunities to leverage those and that payment source in some other ways that could help increase access across our state. Rural hospitals have a lack of ability to provide specialty services. It's also, if in the industry, it's not a secret where our profits come from. I mentioned they come from commercial payers, but they also come from primarily surgery and imaging, especially in hospitals my size. That's where they, and so a very rural hospital that has not been able to keep an operating room open or can't provide MRI services probably is not going to have the profitability of the hospitals that can. That's just the reality. There's a lot of cost shifting in healthcare. We provide a lot of things that we may be able to break even on or lose a little, but they're all supplemented by these things that pay quite a bit so that you can basically provide the whole. Kind of the benchmark in the industry is you need to make between a 3 to 4% operating margin to be a healthy, productive hospital so that you can update your plant and equipment, so that you can provide raises for your employees. And then, as Dr. Shrum mentioned, the healthcare workforce and recruiting problems. In rural, it's probably exacerbated. There's studies out there that show young people in training today are moving to the cities. There's books written about the urbanization of America. I mean, that is a reality that we face in rural Oklahoma. But I think there are ways to combat that, and I'll mention a couple of those later, but I could never do as good a job as Dr. Shrum just did on what some of those opportunities are. I want to mention this, too, to talk about Medicaid and our Oklahoma Healthcare Authority. This was surprising to me, and I actually just learned this in the last week or two as we were researching for this presentation, that our healthcare authority right now, on average, of all the enrollees in Oklahoma, per person spends $5,600 per enrollee in Oklahoma. That's the 14th lowest in the country. We are the lowest spend per person across our contiguous states. Almost all of those states that we're compared to have Medicaid managed care, and we don't. And there's definitely some additional costs involved if we were to go that route. I am not necessarily against managed care. There are many principles within the managed care world that I think we can adopt that we can do better at. I think competition facilitates better health care, and I think that we can do better than we're doing today. But my point here is our healthcare authority does a good job. We get paid quickly within 14 days. We don't have to do the games that we have with many of the commercial payers that are there. And I think the big point here is if you look at the way commercial insurance companies, what they talk about, their administrative load is less than 15%. The Oklahoma Healthcare Authority is just below 5%. That 10% delta, if you add 10% to $5,600 per person, our cost will be about what the regional average is. The problem that I have with Medicaid managed care is that it's usually not Medicaid managed care, it's usually Medicaid managed payment. There's only 3 ways to save money in our Medicaid program: reduce eligibility, increase premiums, or cut payments to providers. And we all know of those 3, which one that generally happens. I also want to thank all of you, the legislators in this room, for your support of the SHOP program. The Supplemental Hospital Offset Payment Program that was enacted several years ago has been a lifeblood or a lifeline for hospitals across our state. We are able to maximize the federal match within Medicaid by a provider fee that gets paid to the healthcare authority, who then sends it to the federal government, and we get a 2-to-1 match. And then those funds flow back to the hospitals. There is no doubt in my mind we would have additional hospitals closed had this program not been in place. SHOP, as we look at and you all discuss, does an Oklahoma plan make sense? Maintaining and preserving SHOP is just critical for that planning process. This is a little detailed bit of a slide, but I want to point out the statement I made earlier about how all hospitals rely on the commercial payers, and that the premiums you all pay for the commercial products are exponentially more than what Medicare and Medicaid pays us. And this slide shows that. If you look at Medicare, gross charges in Oklahoma in 2017 were $18.4 billion. And the net revenue, another way to say net revenue is collections. How much did a hospital get paid? Was 37% of the total. And if you look at other third-party payers, which are those commercial payers, their total charges are about $15 billion, whereas the total collection is 47%. And so while we will see and treat, at Duncan Regional, 28% of everyone we treat is commercial payers. So the way to translate that is 28% we can make a profit on. 72% of the work we do not. And I would say, because I've already told you I've worked in those other hospitals, that we're all very similar. There's not a dramatic difference depending on, I mean, there are several communities in our state that you can compare that are similar, and the ones I've worked in are definitely that way. I think this is an interesting slide too, because it gets to that, what's the difference between urban and rural hospitals? So the column on the left is the payer mix for urban hospitals, on the right's rural. And you can see what I was describing earlier. The Medicare mix goes from 35% to 44% urban to rural. And then the commercial payments go from 50% to 37%. Medicaid, interestingly enough, is similar. But the self-pay, or I usually refer to as the uninsured, goes up in the rural markets. And these are averages, so you're going to find, you can definitely find hospitals that that's not necessarily the case in urban and rural, but that certainly bears true in most cases. How many of you have seen this slide before? I'm going to guess a lot of you. Almost, I just pulled this, I went to Googled this for this slide and pulled it off and put it in the presentation. And there are like 10 of them if you Google it. It is, I've seen this probably at least once a year in some healthcare consultants' presentation to describe the disparity between what's happening in the United States versus the rest of the nation, or the other nations of the world. And why do we spend so much more? And that we have to do things differently. And, you know, we've all scratched our head. I've mentioned some things that we could imply contribute to that. But how many of you have seen this slide? Because this was one of the biggest aha moments for me maybe 4 or 5 years ago when I did see this. This came from the Commonwealth Fund. And if you look in the middle, the total bar shows the total costs. And in the middle is the United States. Well, what are they measuring? The dark blue is how much we spend on health care as a nation. The light blue is how much we spend on the social determinants of health. And Dr. Shrum just spoke about those too. When you add the two together, we're right in the middle of the pack of these industrialized nations of the world. What we do is we spend our money on health care. In treating disease, we don't spend our money on preventing it. So as we look at Oklahoma plan ideas, there's no question that the social determinants of health, if we're going to become a healthier state, we're going to have to put some thought into what those are. I'll just add, yesterday we have a community health improvement organization. Some of you may have heard of those, CHIOs. And ours met yesterday. And our leader of our health department showed a video called Resilience. Have any of you seen Resilience? Senator Scott was there with me too. And it was really eye-opening. And it talks about a program called ACEs, Adverse Childhood Experiences. And I'd never heard that you could actually correlate things that happen in your childhood to chronic diseases. Things like cardiac disease and obesity later in life because of things you may have went through as a child. We've had a couple of events in Duncan in the last 10 years that have sent many of our community leaders scratching their head. How do we solve this? There's no doubt in my mind investing in ACEs could help us do a better job in some of the things in all of our communities that we all struggle with and want to do better. But that's a great example of what the social determinants of health are. I love this slide. I know you all have seen this. It came from the health department. It does such a great job of simply showing how social determinants impact the health of our state. I love that Governor Stitt has basically introduced to our state this mantra for top 10. How do we be top 10? And what does that look like in health? because we typically don't talk about how great is the hospital. We talk about the health of our citizens. And I think we all could agree that that really is the goal. But for this to show that 65% of our deaths are attributed to cardiovascular disease, cancer, diabetes, and lung disease, and then to show that those chronic conditions are primarily influenced by tobacco use, poor diet, and a sedentary lifestyle, it just draws kind of dead aim at what we have to tackle if we want to do this long-term play of making Oklahoma a healthier state. I remember growing up as a kid in Lawton in the 70s, and I was in grade school, and I'd get a sticker that I'd wear home, and it was a frog that said, "Kiss me, I don't smoke." Some of you will remember that campaign. And that campaign, if you look where we are today, we have reduced tobacco use dramatically over those decades. But that's the kind of struggle we're going to be in on improving the health of Oklahomans. And these are the kinds of things, there's strategies out there that we could implement that could help us be a healthier state. Representative McIntyre sent this out in a tweet a week or two ago. And so I always look at his stuff, and I look at your stuff too, Senator Scott, just, I immediately expanded Stevens County. And there are 5 or 6, they've got to be census tracts because they don't marry up with their zip codes, that show Duncan. And where I live, the life expectancy at birth is 80.4. And in our same community, there's an area that's 67.5. Within 5 miles of where I live, it can be that dramatic. And there are things we can do, and I would bet ACES falls into that too, that I know that we can impact the health of our areas if we can dig a little deeper into what's causing some of this data. If you all, as the work group, haven't seen the resilience video, that'd be a great thing to show here sometime if you have time. So some of our rural health challenges, to start to summarize, workforce absolutely is a challenge. We have a partnership at Duncan Regional with Oklahoma City University to train and grant Bachelor of Science of Nursing degrees on our campus. We've invested in a long-term or a nursing facility so that we can train nurses. It's a big deal for our community. It helps us keep our cost of agency and contract nurses low. Access to behavioral health is a big deal that we need to expand. You've all heard about the opioid crisis. We all have problems in our areas that we need to invest in. Ambulance availability has become a big problem, especially in rural communities. As proud as I am of our organization and what we're able to do, there's a lot we can't do. And if our system fails our citizens, often that failure will be it's a critical moment and we can't get a transfer out. And you all know the cost of helicopters. They get called because often they're available. The ground transportation system is not as available. We don't have enough paramedics in our state. We need a plan around training more paramedics too. And we probably need more regional plans to provide ambulance services. And I'm not advocating for government to do that. I think there are a lot of independent businesses that can do that we can work with to try to incentivize and make better. I mentioned these last two, long-term care, nursing homes, and pharmacies, because in our work in Waurika, and even in a previous job where I worked with some of these smaller communities, it's kind of at a fundamental level what I've seen is if you've got a community of, say, 2,000 people, and you've got a doctor, a nurse practitioner, a nursing home, and a good pharmacy, you can provide, there are programs and ways to put together access points for people in these communities. And I think what's interesting to me about that is that we have so many communities in Oklahoma of 2,000 people-ish. We've got 2 clinics in communities of 700 people. So there's ways to do this, to do the access points and be able to afford them. It just may take us all planning and thinking a little more together. So solutions, absolutely expanding Medicaid, doing an Oklahoma plan, accepting the federal funds, whatever language we'd like to use. Any of those things are going to help rural Oklahoma. We need a workforce plan to ensure a better adequate supply for our doctors and our nurses. Those are both critical. I throw in paramedics. I mean, there's other shortages like laboratory technologists, physical therapists. There are lots of the healthcare careers that we could work toward. We need incentives to encourage people to move and live in rural Oklahoma, and then to ensure an adequate supply of ambulance coverage. And why support expanding Medicaid? I don't know any hospitals that don't. I know none of you are surprised that that'd be my position. But we also support an Oklahoma plan. We support accepting the federal funds. And if we can come up with a system that's smart and works, well, let's see if let's work on that together. But as the second highest uninsured rate in the nation, why are our hospitals failing? That's one reason. It provides a 9-to-1 match. I don't know of another government program that's ever done a 9-to-1 match. And I mean, so I think that's a huge boost for our community, for all of our communities. It stabilized rural hospitals. Absolutely, we can create more access to care. It would absolutely help pay for substance abuse and mental health treatment. Really does provide a hand up. Most Medicaid recipients are work. And for them to come to their doctor or their hospital with the ability to pay for it increases their self-esteem, but it also increases their confidence that they're going to be able to continue to get the care they need, especially if they're managing these chronic conditions. It provides coverage to 200,000 of these Oklahomans, bring our Oklahoma tax dollars home. Every one of us in this room are paying the tax. It's being paid. It's not, we don't have to go out and ask for the citizens to give more. And it will create jobs in healthcare and other related businesses. I was with a peer last week, and we were talking about this. And he told me that a few years ago, when we didn't accept the federal funds, their organization elected to not do a multi-million-dollar expansion that would have added 900 jobs. And this organization was in one of our 2 metro areas. But the thought occurred to me after he told me that was, how many other examples do my peers have that would have increased access and increased care and provided economic development in all of our communities had we taken that money? Hospitals provide more than $1 billion in uncompensated care annually. That's our cost. That's the Oklahoma City region, Tulsa region, and rural regions for uncompensated care, charity care, and bad debts. It's real, and it makes running this type of business harder. If you can imagine, any of you as small businesses, if you had to give part of what you do away, it would make it more difficult for you, for sure. You'd have to have a higher price for the people that are paying you. And then the federal EMTALA program certainly has an impact on that. Does Medicaid improve health outcomes? There's starting to be several studies out there that show that it does. The Atlantic published just at the end of July, opt-in states experienced a 9.3% reduction in mortality rates, 50% greater reduction in infant mortality and Medicaid expansion. The 22 healthiest states have expanded Medicaid. Medicaid expansion was associated with a significant reduction in the proportion of adults with depression. There are more. These are just examples of ways that access to care, more than expanding Medicaid, access to care helps people, helps our citizens. And then finally, this is my last slide. It's a huge economic impact. How many businesses in our state even generate $900 million in revenue for our citizens? There's not many, and this is just to add to. Healthcare and social services together, the way our local or our state department measures it, is the largest employer in Oklahoma. And we've all been to other states and seen investments and developments in more robust healthcare systems than we have here. We could bring that home and do more here. If these were matching funds for other industries, if it was matching funds for the military, transportation, education, FEMA, we had already taken it. I'm not sure. I'm not going to say that because I know why it didn't happen. We all know why. The politics around this law and this debate have been sticky. There's just no way around it. They have been, and they've been hard. And I appreciate the fact that y'all are even talking about this. And I recognize that it's, for many of you, a stretch to do that, and I thank you for doing it. I think this kind of dialogue is healthy for our state. we can move past ideology, and I have no doubt that we can create a top 10 state. Our state is full of compassionate and exceptional and brilliant people that can do this. And many of you are in this room. I really do appreciate your service and appreciate the fact that you invited me to be here. I love our state, and I love what we do as an industry. And if you've ever worked in healthcare and you get around the people that work at our organizations, it is more than just the paycheck for these kinds of jobs. We really do wake up every morning thinking about how to make our communities better and how to serve the people that come to us healthier and a better place to live. So I look forward to taking your questions. Representative McIntyre, you want like me to introduce Mr. Spicer, or would you like to? I'll introduce Chuck Spicer, who's been a colleague and friend for a long time. We actually started our careers together in Dallas. He was at Presbyterian Health System, and I was at Parkland Hospital. And we always kind of get together and go, how did we just said this morning, how did we get here together? That was 25 years ago. So he has been a tremendous leader, advocate, friend for our state, and I think you'll enjoy listening to Chuck. So, Mr. Chuck Spicer.
Mr. Spicer, please introduce yourself before you speak.
Okay, and I think I've got a new slide deck, so I'll let that get changed over. Good morning, and thank you for allowing me to speak today. It was 15 years ago this month that I received a call from a recruiter to come look at a job in Oklahoma. And that job was the CEO of the Children's Hospital. And it was an incredible job and the beginning of an incredible journey that brought me here and has kept me here now as the CEO of OU Medicine. As Jay said, I started my career in Texas. I'm a native Texan. Please don't hold that against me. I'll reference that maybe again in a minute. But I'm rooted in Oklahoma. I raised my children here. I'm married to an Oklahoman. My brother-in-law's in the back of the room. Don't raise your hand, Mike Osborne. But that just tipped my hand there. So I am stuck here. I'm going to spend some time. Jay and I have a lot of redundancy in our slides, so I'll try to skip through that as much as I can. I may reinforce some points he made. I'm going to start a little bit with OU Medicine and what we do for the state. We're a bit of a unique health system compared to some of the others. We are proud that it does start with a brand, and we are the state's only completely integrated academic health system. When you take the 7 colleges under the Health Sciences Center and put them on the same campus as 2 major hospitals, that delivers something unique. And I'm privileged to follow Casey, which also plays Dr. Shrum a unique role in our state in Tulsa. We have a little bit different platform given our integration as a campus. But it does start with a brand, and I know many of you are Cowboys in the audience, and that interlocking OU bothers you. I grew up a Texas Longhorn fan. I can tell you I got to wear it on my chest every day, and my dad still doesn't forgive me. But it is a powerful brand nationally. It helps us recruit physician talent, and that's important. But our assets also amplify the brand. The hospital assets, we're the state's only freestanding children's hospital, the state's only level 1 trauma center. We have access points across the state. We have telemedicine and outreach that occurs across the state. And it's interesting that you see most of those assets concentrated around Oklahoma City, including the Stevenson Cancer Center, which is really, we're proud, is NCI designated into top 50 cancer hospital by U.S. News and World Report. While that's heavy metro-based, if you look at those million patient encounters down below at OU Medicine, those come from every county in the state of Oklahoma, from all 50 states in the United States, and from over 12 countries. And that also positions us uniquely as a health system. I'll point out that the 3 largest providers of rural health care are not rural health systems. Interesting. Integris, OU Medicine, and St. Francis. So while we're giving you the urban perspective, we have a very vested interest in the state of rural health. We don't operate a rural hospital. Integris and St. Francis both do. But we have a lot of patients that depend on our care. And we sometimes get those patients too late in the episode of that care to provide effective treatment. I'll get back to that in a little bit. We are a newly owned, newly created company. We're 100+ years old, but we are a public-private partnership that started back in 1998 with a partnership with HCA. In 2018, February 1, we bought at HCA. We became a locally owned health system. We're one of the 3 locally owned Oklahoma health systems in the state with St. Francis and Integris, and we're proud that every dollar we generate has to be reinvested in the state of Oklahoma. And our mission says to improve health, and we take that investment to make sure we do that. We have a board and a governance structure that's appointed partly by the legislature and the governor, through UHAT, the Hospital Authority and Trust, partly through the regents, and then a third come from the community. The reality of them is they're all Oklahomans, and we are a private organization not owned by the state or the university, but UHAT is a sole member of that 501. So we continue that private-public partnership that was started in 1998. I go back and go over 100 years, or really two. I hope this is a pointer. The JOA, which was formed. The hospitals downtown, Children's and University, were about to close in the mid-90s. Some of you will remember that. And the public-private partnership not only saved those hospitals, stabilized those hospitals, they created financial stability, which created financial strength. But as you fast forwarded 20 years, by the 2017 timeframe, we saw dollars leaving the state, getting distributed to HCA and not getting reinvested. So the big reason behind this change to be locally owned is, again, channel all those investments back into the state of Oklahoma. You can see what happened to the campus. This is 1997. Currently, a lot of changes, a lot of building improvements. The trust you had a lot to do with that, but this made our campus and our Health Sciences Center become and get into national prominence. And then a new picture of our new tower that's being built with a downtown area. Obviously, we've benefited from the urban improvement of the downtown infrastructure, the innovation district that now ties downtown to OUHSC. This building will not have beds like we have at our other community hospitals. These are built for high-end cancer care, level 1 trauma. We've been at or above capacity for the last 7 years. Patients that need these services often have to leave the state. So these are unique and essential investments to keep people in our state, not that necessarily duplicate services. This is our payer mix. Jay talked about the difference in rural and urban, and ours is different. We are the state's safety net. We take uncompensated care. We take the most complex care that others can't take care of, and it does put a strain on our payer mix. I'll point out probably most prominently is that 12% in self-pay that hasn't changed. 35% in Medicaid, by far the largest Medicaid provider in the state of any health system, largely because of children's and women's. But the Children's Hospital has about 70% of its patients covered through the Medicaid program. If you line that up to the state averages that Jay showed earlier, you got 2.5% and 5% self-pay versus our 12%, and the Medicaid rates don't compare either. So we are disproportionately covering Medicaid and self-pay patients, which are underpaying us. Self-pay equals no pay. These are not people that are coming in and paying cash. They're coming in and having charitable care provided to them. Our challenges are abundant, and I say statewide because we really share these with rural Oklahoma. The fact that the state has overall declined in their health. 20 years ago, we were middle of the road. Now we're bottom 5. That puts a stress on health systems and hospitals across the state. We have intense regulatory pressures. I've had 20 regulatory surveys in our hospitals this year alone. Take up an inordinate amount of time. They add additional capital demand to an already capital-intensive environment, and we may need your help on that. I know the governor's reached out to help us with some regulatory pressure easing. We have an uneven playing field. What do I mean by that? We have hospitals and we have ambulatory surgery centers that limit the care they provide to certain insurance categories and to certain age and disease categories. And there's a lot of talk about how they can be really transparent with their costs. Well, it's really easy to be transparent with your cost when you only provide care to this small circle of people. We take all comers, regardless of age, insurance payment, or disease state. And that puts a really stress on our emergency rooms, whether you're rural or urban, that we got to take everything that comes through our doors. We do have to be ready all the time. We're the only level 1 trauma center in the state. We're proud of that. We also have the only biocontainment unit in the state, which we developed after the Ebola scare several years ago. We took an old discontinued unit in the old Children's Hospital, brought it back to life. We have readiness 24 hours a day for any pandemic biocontainment threat. that we can open up those beds and use those to get them out of a hospital in Duncan or at OU Medical Center or at Baptist Medical Center. That's there, and I think it's a great source for the state, and we did that with very little state support on our own. Physician and workforce is a major challenge. We train the largest number of physicians in the state. We still don't train enough. We train a lot of nurses along with Duncan and others. We still don't train enough. And that's really affecting more than anything the access to care. An example of how rural access to care impacts OU Medical Center or OU Medicine. This is a real example of a farmer in Sayre, south of Sayre. Got a cough, got sick, got a fever, put it off, too hard for him to travel to the nearest doctor. 10 days later, he couldn't stay away from the emergency room any longer. And his simple pneumonia had turned into septic pneumonia. The Elk City Hospital could not take care of organ failure that was setting in on the septic patient. And he was transferred to OU Medical Center, where we saved his life. But the reality of it, he could have been treated on an outpatient basis with antibiotics and never left his ranch. And that didn't happen because we don't have the right access. We all have economic pressures. The states do, the hospitals do. Jay went over a lot of that. I'm not going to rehash that, but we get that this is not something that you guys can solve easily either because you have significant financial pressures too. And a lot of that is around the uninsured and underinsured population. If you took Medicare, Medicaid, and self-pay or uninsured, we have a high percentage of that, the second highest uninsured in the state. If you add all three together, I can't find those statistics, but I bet specifically in rural Oklahoma, we have the highest in the nation. Texas is the highest uninsured in the state or in the United States. They also have one of the highest insured populations in the state because of the economy. Just a little bit of an idea in the marketplace. We have a lot of assets in the urban setting. We have 5 health systems in Oklahoma City that duplicate a lot of services. That creates some competition. Also creates probably opportunity for some rationalization and partnerships that I think we're open to. We have a high percentage of physician-owned hospitals, which create a little bit of a diseconomy for people that don't have coverage. These hospitals are for-profit. They're not necessarily built to take care of all. Some of the complex care that they have at a spine hospital or a heart hospital often ends up at another major hospital because they don't have the capability to take care of it. In Oklahoma City, we have 2 Oklahoma-based systems, Integris and ourselves. The physician platform has changed a lot. 15, 20 years ago, most physicians were independent. Now most physicians are employed by a health system. Primary care access is good if you've got Blue Cross. It's not good if you have Medicare, Medicaid, or self-pay. Physicians will limit their panels for how many Medicare and Medicaid patients they will take. And I'll get back to that again in a minute relative to Medicaid. That creates gaps because while you can make money in certain specialties, it's hard to make it if you're an endocrinologist. We have a lack of endocrinologists in the state. It's hard to make it if you're a rheumatologist. These have to be subsidized. We don't have enough of them already. So not just primary care in rural areas, but subspecialty care in urban areas is a real problem. Again, this forces chronic disease management into a primary care office or into an emergency room, which is not the best place economically to provide it. And then we have one major insurance company, and that does affect our ability to compete. We don't have quite the balance that you see in Texas of multiple insurance companies with similar market shares. We have one insurance company that's market share dominant. The Tulsa market is a bit different, not as fragmented. They have 3 health systems, not including the Cancer Treatment Centers of America. To give you an idea, when I say fragmentation, 5 in Oklahoma City, not including community health, for 1.5 million people. There are 2 in Austin, Texas, if you don't count Baylor Scott White, which is in Round Rock, for 2.2 million people. That impacts workforce, it impacts rationalization of care, and it does impact costs. But the Tulsa marketplace is really concentrated their market share in the northeast quadrant of the state. There are fewer physician-owned hospitals. They have the same physician platforms and realities in the market share in health insurance that we do. We do bridge the gap. Jay talked about SHOP. We are not participating in SHOP. We participate in THRP, which is unique for us as a trauma center and a teaching hospital. It's basically the equivalent of SHOP. We also put up a match. We also get IME and GME money and DISH money. These are limited. These are not growing. This is not something we're going to depend on for additional supplemental payments, but they're critical to protect for all of us. Combined, you're talking about $700+ million in supplemental payments for hospitals and health systems across the state of Oklahoma. That's a lot of money. I think the number, and if you count some of the other programs, could be in excess of $800 million. We don't train enough doctors. Dr. Shrum talked about this. I know you can look at our per capita at 276 across the United States. We're at 205. And this is with a rapidly aging population and a rapidly aging physician workforce. We have 72 to 77 counties that are designated as shortage areas. You guys know this. The answer, you think, is to train more doctors and educate more doctors. It's stress on OAU and OSU to train more in terms of the undergraduate and graduate programs. We're limited in the ability to grow our medical schools. And even when we grow them, what really matters is a postgraduate training, resident and fellows. Those are the physicians that will go into the workforce. We are in the bottom 5 of the United States in the number of residents and fellows we train per capita. The good news is the ones we train, we're really good at keeping. We're actually almost in the top 10 of our percentage capture that if you train at OU Medical Center, you stay and practice cardiology somewhere. That's really good, but we've got to train more. And there's no more funding. The GME funding provided by Medicare is really washed up for everyone. There's no additional state dollars that have been put to this. This is, I think, an interesting use for when you accept federal dollars and maximize those, how can that convert into training slots we could help the access? Workforce shortage in nursing, same issue. Also really difficult to train more nurses and educate more nurses because it's hard to commit to being a nurse educator when you can make more money in the ICU. And that's a real issue. I think the other part of this is health isn't the only answer to equaling and improving health care. There's a lot of issues around socioeconomics, housing, food, transportation that affect that. Jay talked about the imbalance in Duncan. Even in our urban site in Oklahoma City, we have 2 zip codes that are proximate to our campus that have the worst health outcomes in the nation. And they can go 3 blocks and go to the ER, but they don't have a good place to buy their groceries. And that's a real problem. This is Oklahoma County. You can see the life expectancy in our is even greater than Duncan. It's an 18-year gap from worst to best. A lot of work we can do to improve health, which will help us improve that life expectancy. Dark green are the worst. You can see those are more inner city. Education, food, income, we know these are issues that do affect healthcare. We have to just focus on broad solutions. It's not going to be a rifle shot. It's going to have to be a multi-pronged solution that focuses on socioeconomic aspects of health, not just access to care. They're all critical. Access is hugely critical, but these are areas that have to be addressed too. Food in general, the number of children in the Oklahoma City School District that are funded by free breakfast and lunch, you guys know the statistics, 90+%. At Children's Hospital, we fed about 8,000 of those this summer. We gave them a free breakfast and lunch through a grant from the Federal Food and Drug Administration. But we've got, if they don't have the option to come to Children's and get a healthy meal, they get it from a convenience store. Or they get it from McDonald's. So, Jay talked about the solution. I used a bit of a different term, maybe that's more palatable to some of you, which is maximizing federal dollars. We're number 2. But the ironic thing about being number 2 in uninsurance is we're in the top 20 in unemployment rate. What does that tell you? That a lot of the folks that are working in our state don't have access to insurance. And I want to help debunk the myth that this access to care that could be funded by accepting federal dollars is for deadbeats. It's not. It's not. I think the number that we've run is almost 200,000 people are working uninsured. So those 2 bullets, just remember, part of it's uninsurance, but also it's the fact that these are working people. Jay talked about the ACA taking dollars away from hospitals. Tax dollars that we're paying in also got diverted to states that expanded. Jay forgot to mention the District of Columbia, Jay, which I know we all value here, but 36 states. And the biggest impact of expansion is impact on access. We will not increase access in the short term. We will not if we don't find a way to maximize those federal dollars that are there for us to take. It also doesn't just improve access for people without insurance or with Medicaid. But if you're the farmer in Sayre that has a policy with Blue Cross, it improves your access. If you have Cigna and need to go to a subspecialist for your diabetes, it improves your access. So I think it's a win-win across the payer continuum. And it could be used, certainly with OU Medicine, to expand teaching and training programs. We know we have about 80 approved GME slots that we could expand now, but we don't have the dollars to do that without taking away from capital improvements, without taking away from nursing staffing. That would take away from other investments we're making. So other considerations, I just want to go through a few of these. I think we've looked at Medicaid rates and cutting Medicaid in the past as a way to reduce expenses. I would argue these have increased expenses. Let me give you a good example. The number of people that will deliver babies in rural Oklahoma has gone down significantly in the last 10 years. Guess what? Women still get pregnant in rural Oklahoma, but they can't get access to prenatal care. So we have weekly a mom showing up at Children's Hospital to deliver a baby at 28 weeks that has had 0 visits to a doctor. No prenatal care at all. The first prenatal visit they have is 2 hours before they deliver. And they deliver a baby that probably could have been a healthy term baby, but that baby spends the first 6 weeks of their life in the neonatal ICU at Children's. So that rate cut that we achieved to reduce payment for an obstetrician visit in Antlers, Oklahoma, maybe increase the overall cost of the Medicaid delivery. And I think we got to think about the overall cost of care, just not the per unit that we're paying. I do think that we want to move to value, and we use the word managed care later. I'll use it. We understand the traditional fee-for-service Medicaid program isn't working. We already participate in value-based care initiatives with Medicare. Risk-reward systems where we have penalties if we do a bad job, if a patient gets readmitted. We also get a reward if we do a good job. But guess what? That happens for those Medicare enrollees. It makes them healthier. And we're willing to partner with you to enter into the same type of programs. Whatever we move into, you have to protect those supplemental payments. Managed care with a capital M puts those payments at risk. There was a time where you could be grandfathered with those programs. That time has passed. The SHOP program, the THRP program, that $800 million would be in complete jeopardy if we're not careful of how we manage that care. And again, managing the care, not the payment, to your point, Jay, is really what we're after. You have to also make sure you don't have an unnecessary impact on those high-risk populations, chronically ill kids, low-income moms, or the elderly, because they could create the overall cost of the episode of care, not just that per encounter cost. Help us with the regulatory burden. Make sure we use some care with transparency. Not all hospitals are alike. You can't look at my hospital at OU Medical Center and compare it to Duncan. We're completely different patient populations. So I think we tend to get all put in the same bucket, and we're not. And it also sometimes is not helpful because we don't have an even playing field. And then finally, I think this stands for OU Medicine's commitment, but also the OHA. I'm a board member of Jay's at the Oklahoma Hospital Association, but I just put this down as a closing comment. We stand ready to help improve the health in the state through growing the pipeline, better managing the Medicaid program, developing statewide partnerships to improve access to essential services, whether that's in rural clinics, partnerships, telemedicine, and aligning around improved outcomes. I think this is something that's not just OU Medicine's commitment, but it's really all of our colleagues' commitment to do. So, under 30 minutes. So, Jay, I beat you for the first time.
Thank you very much, Mr. Spicer. Okay, so we can take a break right now. Members, do you want to take a break or do you want to just push through? We do not have an afternoon session. All right, so ruled. We will push through. We'll start with Senator David.
Thank you, Mr. Chairman. Hey, last time I was last in the question queue. This time I'm first. I'm getting ahead. Thank you.
I'm going in order, Madam Leader.
Thank you. No, I know you are. I'm just giving you a hard time. I guess if either one of you guys could answer this question, whether it's whether it's Jay or whether it's Chuck. Thank you guys for being here today. I appreciate everything that you're doing in Oklahoma for healthcare. I do have a couple of questions, though, that I think it's important to bring up. What is the reimbursement rate for doctors in Oklahoma?
That would depend.
I think it depends on the doctor, it depends on the specialty, depends on where they're located.
Okay, let's, and the only reason I bring that up is because one of the slides up there was talking about Medicaid costs by state, the regional Medicaid costs by state. So the average, do we have an average, or we can use family medicine when we're talking about reimbursement rates, but is it not true that Oklahoma has one of the highest reimbursement rates in the region for our physicians?
I don't know the answer to that.
Well, I will answer it a different way. The amount of dollars we have to use to subsidize physician payments has gone up exponentially because they're not able to generate enough money from their clinical practice to pay their salary. And we can argue about whether physician salaries are too high, and that's an argument that maybe we need to have, but it requires a market competitive salary to get a doctor to move to Oklahoma. And we know the subsidies the hospital have faced have gone up, and I can give you specific amounts that OU Medicine has had to pay to support OU physicians because they can't make it on their own, especially if they're kind of an esoteric specialist at diabetes or endocrinology or pulmonary. Pediatric specialties are really difficult. We do have enhanced Medicaid for children's, but that still doesn't help us pay all the physician compensation.
But it's a similar story with us as well. We subsidize virtually every physician practice, and in rural, what you look at is the salaries you have to pay to get the specialties and the primary care that you want. You often can't generate the revenue in their practices.
If you're a neurosurgeon in private practice, you're also able to really determine what your payer mix is. You can limit your panel of Medicare, Medicaid, and unfunded, therefore increasing your compensation. But again, back to my earlier point, those patients still have a brain tumor, they still have epilepsy, they still have a stroke. So sometimes that limiting factor that does increase compensation for a doctor puts that patient in an emergency room or in an indigent care clinic. We do have indigent care clinics at OU Medicine for specialized care, but the payments are nowhere near what they are in the private practice community.
Follow up.
Thank you, Mr. Chairman. Believe me, I was not arguing that we pay too much to our physicians. I'm simply going back to comparison to regionally what Oklahoma pays, because we do pay one of the highest in the region. And believe me, I'm fine with that. In the years past, when we've had to cut rates, it was only because of budget problems, and I believe we went back as soon as our FMAP increased. We made sure that those rates went back up. What I'm getting to is because of that slide that Jay brought on the regional Medicaid costs by state, we do pay some of the highest in the nation. How does that compare to our health outcomes regionally? Can one of you guys answer that?
We're 47, so obviously we're not generating the outcomes we need to get. There's not alignment around value. And I think we're ready to work on that value proposition of improving care and outcomes. I don't think the argument, I'll go back and look at the payment rates per doctors, and we're a hospital association, not a physician association, but given our subsidies going up and knowing what it takes to recruit and retain physician talent, I don't think overpaying physicians is really our problem. I do think alignment around outcomes is.
It is important to note that the SHOP program we both talked about, a chunk of that provider fee that comes back, it doesn't all come back to hospitals. It goes back and helps supplement physician payments as well. So hospitals are contributing to help make that happen. One of the things that's happened across our state is, as Chuck mentioned, so many of us we employ 55 providers in our system. I think we have 9 left that are independent. And that's not a strategy. That's the choice the doctors have asked to be employed because of the burdens of medicine and the high cost of electronic health records and being a doctor and managing a practice. It's just what they're willing to do today has changed, which has caused a cost to the health systems.
Follow up.
Thank you. Speaking of the SHOP payments, I know that CMS has put more emphasis on those payments being linked to provider care, to patient care, and to seeing an increase in health outcomes with the patients. Do you know how you guys plan on working that with the payments how we currently have it structured in Oklahoma to receive SHOP?
To my knowledge, that hasn't come out. I think there's been some conversation around it, but I don't believe we've had any specific guidance on that. I'm just not aware of it, if that's true.
Okay, I knew that the discussion's been going on for several years about with 1115 waivers that, and if I'm not mistaken, Oklahoma has been told that we have to restructure how we do SHOP. So if I'm mistaken in that, then maybe somebody can address that. And I think this group has. I'm sorry, can I follow it, please?
Absolutely.
Thank you. I think we've already established that the statistics that are out there on the uninsured rate in Oklahoma are a little suspect because they don't take into account tribal members who are insured, self-insured through the tribes, which in Oklahoma that can be pretty substantial in my part of the state and in southeastern Oklahoma. So let's go to what funding we could lose if we expand Medicaid in Oklahoma. The dish payments that you guys receive currently, do we lose that federal funding if we switch to the federal funding coming in through the expansion of Medicaid?
I think there would be some change in our THRP funding depending on the uninsured rate going down, but the bulk of it would stay intact. It's hard to tease out that amount of money, but yeah, I mean, it would be a shift, but it would see a significant net gain.
Yeah, the net effects is definitely weighs in the hospital's favor, even if you have some dish reductions.
Okay. I'll concede for now.
Thank you. So, gentlemen, I don't know if you guys have tuned in, almost everything that, or everybody who's presented has talked about social determinants of health. Everything. Appreciate the slide overlaying social determinant of cost on the overall cost of healthcare and that we're not that out of whack, but we do pay a lot for healthcare.
We do.
So is this argument really about access to care, or is it about a cultural issue that we have, about personal responsibility? I mean, are our health problems really because we don't have enough access to care, or is it really about we just have a really unhealthy population because they make really bad decisions?
I mean, I think you can't say one or the other. I think it is both. You talk about the right to bear arms. I think the right to eat a Big Mac is equally important to the United States. We make poor decisions, and to mandate and legislate how we do that is going to be really difficult. To give options, certainly for children, for healthy meals is something we have to focus on. But we do have a culture that doesn't eat the right things, it doesn't drink the right things, it still likes to smoke the wrong things, and that impacts health.
It's a bit of an all the above. Access, if you're engaging in unhealthy behaviors later in life, you're going to need access to health care to manage what you've created. So it's chicken and egg.
Senator Quinn.
Thank you, Mr. Chairman. To our speakers, I appreciate your time and the information. I promised myself when asked to serve on this task force that I would do so with a open mind and one that was looking for a solution. My wife spent a number of years in hospital administration, so I guess I'm saying that I don't want to be looked at as your enemy, but I am going to ask some questions so that at the end of the day, hopefully we can walk away one of these days with a solution that gives us a better medical system for the constituents that we represent, but also beneficial for the industries that you represent, and improve the outcomes for our state. First and foremost, we continually talk about the 9-to-1 match from the federal government. And I know that there's a number of examples out there that the federal government promised that it would pay X if we would invest Y. So my question to you is this. We know that those are our quote, our tax dollars that we would like to get back and spend here in Oklahoma. So if we add 250,000 more people to these type services based off of what we say that we're going to get from the federal government. Federal government has something in excess of a $22 trillion debt, and I'd hope that we would realize at some point in time in the future that is going to be an issue for this country. It is an issue now. It will be an issue in the future. I just hope not as traumatic as it could possibly be. But if we wake up 5 years from now, and we have banked the services that we have built for this population that we're talking about adding, and that match goes from 9-to-1 to 5-to-1. What do we do then? And I have like 10 follow-ups.
Well, 5-to-1 still is 5-to-1. I liken it to other federally supported programs and industries in our state, that if there was a base expansion initiative to add $200 million to one of our bases, knowing that there's been base closures before, we'd still take the $200 million. I don't think we would ever ask the question, what happens if there's a base closure in 10 years? Because there have been those. So I do think you have to take the short-term gain, realize if there's a pivot down the road, we pivot together. But obviously we understand this is scalable up and down depending on funding. But I think if it's a road or a bridge or an Air Force base, we're not asking that question. For whatever reason, we have to ask it about health care. But I appreciate the question. But I just think you look at it compared to those other analogies, and we've dealt with those things when they come up, but we've not accepted the money because of what might happen in the future.
My question is not that we don't accept the money. My question is that we're banking on 9-to-1. It's reduced to 5-to-1. We've had testimony here multiple times over the last several weeks that individuals that talk about states that have currently taken those dollars, I think the total is 36, those states have realized that the expected cost to them has been anywhere from 2 to 4 times greater than what they assumed when they went into to accepting those federal dollars. So not only if the costs are higher, but if the federal government lowers it, my question is, where does that money come from? First of all, we don't have a funding source. To my knowledge, we don't have a funding source to give you the 1-to-9 match. So if that match is reduced, where does the funding come from? How do we adjust an $8 billion budget if we have a 6, 7, $1.2 billion swing because of what we've accepted here?
I think we have worked on some funding sources to minimize the impact on state funding now. But the answer I had is it's scalable. We scale now when payments go down with Medicare and Medicaid. When programs close, we scale. It's not always easy. We scale up and down. It will affect the health system if it affects access. But I think that's not, again, that's something we'll have to address together. I don't know how you predict that. But to go back to your question of them, I think we're willing to work on how it gets funded when we're able to get engaged on that.
It's my understanding that we have some funding sources within the health departments, the different organizations we have that could help contribute to that match by reallocating where those are. I can't tell you the details, but it's my understanding we can come up with that.
Follow up.
And I didn't hear the last part of Mr. Spicer there, but will you expand on, because my question is where is that funding going to come from?
Well, I think it basically says the same thing, Jay. We were aware that they were working on some funding methodologies in the last session. I don't know the details of those, but I think they involved, rechanneling dollars that were already out there, not creating a bunch of new dollars. But I would defer to people that were involved in that more than myself, because I'm just more peripherally aware of it. But we're happy to engage on it.
Follow up.
Thank you. One of the slides that you have, Mr. Spicer, is it shows that Oklahoma is, 26% below average as far as the active physicians. If we're using that as an example, where do we compare population-wise? Because if our population is lower than the vast majority of states in the U.S., shouldn't that be a factor in this slide as well?
I'm pretty sure it was a per capita slide, so I think you adjusted for the population. This is active physicians per 100,000 in the state. So there are 276 across the United States, an average per 100,000. In the state of Oklahoma, it's 205.
So does that go back to Oklahoma being just a sicker state, medically speaking?
No, I mean, this is speaking to the physician infrastructure and it being lower than the average across the United States. Does that make us sicker? I think it has an absolute contributing factor to it.
Follow up.
Well, my point is that if we don't, if our population is not as sick, we don't need as many doctors. Is that correct?
I think the opposite is true. I think that to get your population well, you need more doctors.
Follow up.
I guess I need to talk to you privately, because it just seems like to me if you don't have as many sick people, you don't have the need. I mean,
Well, I would also defer to the physician probably, and Dr. Shrum could comment on that as well, but we can absolutely talk about it over a cup of coffee, and I think it's shown that healthier states have better access to care. And access has something to do with the physician distribution per capita. If you can't get into a doctor in rural Oklahoma, you're not going to get well when you do get sick. And you may not stay well because you don't have access to preventative care. You don't know that you're developing diabetes.
I appreciate your help.
Thank you.
Thanks.
Senator Hicks.
Thank you, Mr. Chair. My question is, both of you guys alluded to, insurance, and I represent the area of Oklahoma City that has the Integris hospital system. So we've had lengthy conversations about, the hospitals that are located in my Senate district being number 2 uncompensated care in the country. So around the conversation of reinsurance and eligibility of waivers to try and stabilize the market with the ACA, do you all see that in states that have, received reinsurance waivers, I guess, could we extrapolate what we might be able to do here in Oklahoma if we were able to stabilize the market?
You know more about that than I do, obviously. I don't know the answer to that question. Do you have any thoughts on it?
Well, I think what we find is the predominance of the uninsured and underinsured population seeking the primary care in the emergency room. And we have a program now that tries to move those patients into a better care setting. But we've seen in certain states that access of ER care for primary care illnesses has gone down. We can give you I can go back and look and research specific state incidents, but certainly it gives them more options versus waiting for an earache to go to their ER. They have an option that is available for them to go to a different level of care.
Follow up.
Thank you, Mr. Chair. Would it be safe, I guess, to say that if we, look at the data for the patients that we are seeing, and you guys both gave some really healthy breakdowns on, kind of where the funding sources are coming from, that those of us who are, on a private pay system or employer-sponsored insurance, we're covering the bulk of what is being collected, and it's just not enough. Would you agree with that?
Yes. We're over $100 million a year in uncompensated care at OU Medicine. Well over $100 million.
Representative Fugate.
Thank you, Mr. Chairman, and thank you to both you gentlemen for taking time to take our questions and speaking to us this morning. I have a couple of questions kind of in different areas, so if you'll allow me a little latitude, Mr. Chairman. The question we had about what I would characterize as deadbeat speculation, would it surprise you to know that the Kaiser Family Foundation's analysis of the Census Bureau's American Communities Survey, this is 2017 data, doesn't show 200,000 Oklahomans who are working. It shows 378,000 Oklahomans who work at least 35 hours a week in one or more jobs that do not have health insurance. Does that surprise you?
No.
Thank you. The 65% slide that we've seen talking about social determinants of health, would it surprise you to know that the America's Health Rankings show that for the U.S., the average is 61%? Does it surprise you that Oklahoma is only 4% different from the rest of the United States in those areas?
I have to understand the analysis a little bit more, but I think that you've got some data that I don't have, but I still think we've got not the access to socioeconomic solutions that other states do, and we have a working population that doesn't have either access to insurance, and they probably still make some bad decisions, but those contribute to the overall health.
Follow up.
Thank you, Mr. Chair. The next question's regarding the 9-to-1 match and the concerns that we have as a state, and I think they're valid concerns, but the 9-to-1 match is a statutory match, so that would require a vote of Congress as well as a signature of the president to change the 9-to-1 match. And correct me if I'm wrong, there are 36 other states that have expanded, and wouldn't their representatives have some say-so on whether or not that would change?
I think they've already, none of them offered to give it back, if I'm aware
I
of
mean,
it.
36 other legislative bodies have thought it was a reasonable thing to do, or votes of the people. Some groups have, but yeah, taking an act of Congress to change it's a pretty heavy lift.
And these include governors from both parties that have lobbied to make sure it stays in place.
Follow up.
This last question is really kind of in a different area entirely, and that is dealing with indigent care. And what's the hospital's responsibility if somebody comes in, they're provided indigent care, and they don't have a place to go afterwards?
We're obligated, as a part of our agreement with the state, to take care of all patients that come to us. And we're proud that that's a part of our mission. But certainly, Jay went over EMTALA, they walk into any ER, they're going to have to be stabilized and treated. Now, a lot of times those patients get transferred to OU Medicine, but yeah, it's an expensive place to provide primary care.
And it's one of the challenges in rural, even around, we have an obligation to make sure that all patients that are discharged have a safe place to go. And so you can really get into some difficult situations where you have people that are staying in your hospital well beyond what they're there for care. They're just simply in your hospital because we can't find a safe place for them to go. And I think that can be, if you live in an area where there's fewer social services, it's more difficult to provide that.
Follow up. Wave. Representative Rowe.
Thank you, Mr. Chair. I have a specific question for Mr. Johnson. Do you guys do OB care in Duncan?
We do.
Okay, so this is kind of a question for both of you, I guess. I'm in a rural community, and we had a hospital till approximately a year ago, and I work alongside two family practice physicians who collectively have delivered thousands of babies throughout their careers. And in some of these small communities, you're not going to recruit OBGYNs because there's not enough babies delivered there. But however, one of you all said something earlier that kind of caught my interest. One of the reasons some of the family practice doctors quit delivering babies in the smaller communities because it's my understanding with malpractice insurance, if you deliver over X number of babies a year, that puts you into a higher category, and you're paying the same malpractice insurance that an OBGYN does. And the same thing with the hospitals, their malpractice insurance rates change. And to be able to provide OB care, you have to have 24-hour anesthesia, which is not happening in some of these small rural communities. One of the physicians that I'm working with now has actually, she's done tons of women's health, delivered thousands of babies. She has partnered with two different physicians in two different communities, one being in Norman, one being in Ada. She has done the prenatal care till 28 to 32 weeks and then hands the baby off to one of these two physicians. We even had one lady we saw until almost term because she didn't have transportation to and from the OB doctor once a week and at the end. So my question to you all is, do you offer any kind of a partnership with physicians to do that? Because what I have seen, not necessarily with either of your two institutions, it's kind of a turf battle, and which is unfortunate because it affects these women that may not be getting prenatal care. But do you all offer some similar scenario that would allow these women to get their routine OB care at the beginning of their pregnancies and then hand them off toward the end for delivery?
We don't currently, not that we wouldn't. That sounds like a really good model. We have 3 OB-GYNs and 4 family medicine doctors delivering babies in our community. So I think we've got decent access to OB care. We do provide an OB clinic in Chickasha, who recently, or in the last 5 years, had to close their obstetric service. And so we send 2 obstetricians there to provide that kind of prenatal care for that community. So it's certainly a model we'd consider. It sounds like a good one.
We provide outreach care and support for maternal fetal medicine high-risk OB in a similar manner, but not general OB care. I think telemedicine for us is an opportunity. We not only have in-house anesthesia 24 hours a day, not availability, but in-house. We have in-house obstetrics 24 hours a day, 7 days a week. So we are uniquely positioned to partner with rural communities, probably around telemedicine, that they can get an OB doc, a high-risk doc on the phone or on the telemedicine screen to help provide consultation. So it's an area I think we can expand into more.
You're recognized for follow-up question.
So, and this is specifically for Mr. Spicer. So currently, your outreach is mainly by telemedicine, but would you consider letting another physician, would your physician groups, and most of our clients that are utilizing this are, the vast majority of them are Medicaid, would your physicians be willing to partner with, I mean, we've got some great physicians in rural Oklahoma, and I think sometimes that fact is overlooked. I have trained as a nurse practitioner with physicians in rural Oklahoma that I would put their expertise up against someone in an urban location any day. But, you know, it's a lot of these women or even patients in general in rural Oklahoma are really, you know, they really like the physicians that they're going to and that they're seeing, and they're very comfortable doing that. And you would not believe the response that we've had to some of these women that want to do their OB care locally. But would your physicians be willing to let another physician follow their patients until, as long as it's a non-complicated pregnancy? Now,
Well,
a high-risk pregnancy is referred, but would they be willing to work with a local physician to provide early prenatal care?
We're taking a strategic plan to our board next month that talks about increasing partnerships, access points, which include telemedicine, to do that very thing. We know we have to be more places than we currently are. Again, I think we're uniquely positioned to do that, so maybe we can talk about your specific positions and opportunities to partner with them. But absolutely, I think that's a great strategy, not for just high-risk deliveries, but high-risk pregnancies, but normal pregnancies, because those normal pregnancies can go the wrong direction quickly as well, as you know.
Members, I want to remind you that these 2 gentlemen are very busy. We have time constraints. If you have a question, please ask a question. Do you have a follow-up? Senator Hast.
Thank you, Mr. Chairman. First of all, first question is for Mr. Johnson, and then I'll get to you, Mr. Spicer.
Sounds ominous.
Yeah.
Hopefully I have the softball.
Well, from a hospital perspective, and, you know, I can, you know, I was looking at the numbers and all that, and I can also, I understand those, because I can tell you of a hospital that's got 61% Medicare, Medicaid, and only 14% commercial. And so that really plays into this. But you know, obviously, Ms. Johnson, you're all in on Medicaid expansion. I think I gleaned that from your conversation. You know, as I look at it, and it's you know, a 90-10 split, so that's going to cost us, depending what numbers you're looking at, 100 to 300 million. And I think as we ask the question, I mean, you brought up ideology. I think it's more fiduciary responsibility. As elected legislators, I think that's part of our responsibility to look at that, and knowing that potentially it could change. But what I'm seeing here, it's being presented almost like Medicaid expansion is going to cover everything, all right? And 3 slides earlier, before you were showing your rural health solutions, you were talking about, you know, the lifestyles, and you know, and we were talking about Dr. Shrum, childhood obesity, all of those type of things. And so I guess my question goes into, do you see Medicaid expansion as the end all, and if not, why weren't some things brought out in your rural health solutions as far as other things that we need to do, because obviously part of this is taking care once they get there, but it's also very important that we keep them from getting there to begin with. Does that make sense? Or?
Well, somewhat. It's absolutely not the end all, but it certainly is a starting point. The additional funds we can use to do a lot of the things that I did talk about. We discussed a little bit around how part of our mission is to improve our community's health. Without these kinds of funds and access points and ability to treat these patients, we can't work towards those community health issues. I mean, the reality is people need to get in, to get seen, to get this treatment, to learn, to be educated and to be treated by physicians and other providers. I don't know if I'm answering your question directly, but I certainly think Medicaid expansion or an Oklahoma plan, and doing it in a fiduciary responsible way, I think absolutely we can do that. I think it will go a long way to helping.
Well, and I guess part of what I want to get across, and I think as I look at it for this committee, is there's more to it than one thing. There's not a silver bullet.
Absolutely.
That everything, we do this one thing and all of a sudden we've got great outcomes.
Correct.
There's more to this that we have to do. Mm-hmm. Agree?
Agreed.
Okay, and that's what I hope we can take some of this conversation to, so we don't just get caught up, we do this, it's one and done.
Yeah, no, absolutely.
Okay. Mr. Spicer, I'm going to ask you a question that I asked Dr. Schramm, so I'm keeping OU, OSU equal here. So, is OU receiving any TSET funds?
Stevenson Cancer Center is, that's a university. That's not a part of OU Medicine directly. The part that's getting the TSET funding, it's going to research.
Okay, but OU is getting...
Not OU Medicine, the University of Oklahoma is.
Okay, and was that a one-time deal or is that an ongoing deal?
My understanding is it's an ongoing funding for, obviously, the research that's going on at Stevenson.
Okay, and do you have any idea what that amount is?
Brian, I think the number is around $7 million, a little bit more than that, maybe 7 to 10 million. Again, that's not a direct OU Medicine revenue source, so I'm not specific about everything around that funding.
Okay, and do you know when that started?
2011, 12, maybe? Yeah.
So about 10 years. So give or take $100 million or so has come into that at this point.
Yes, and I think hopefully the state can look at the investment return on an NCI-designated cancer center with a significant amount of clinical trials is keeping more people in the state of Oklahoma for cancer care. So I think there's been a ROI there.
Okay, all right, thank you.
You're welcome.
Co-Chair McCourtney.
Thank you, Mr. Chair. I'm going to jump around a bit here. I wrote questions as you went along, and some of them have been asked, some of them hadn't. I'll start with, there's a slide on on gross margin of hospitals in Oklahoma, showed a pretty dismal picture. I was wondering if you have information on gross margin of hospitals nationwide. I mean, is this an Oklahoma problem or is this a national problem? Because I know a lot of times we look at numbers, especially in this committee. I think we've seen a lot of numbers that paint a really bad picture. And then you realize that that's not actually an Oklahoma problem, that this is the United States, we've got a problem. Sure. So is that an Oklahoma issue, or is that nationwide hospitals are struggling financially?
I can't give you the exact data on that, but we could certainly pull that information. But what I believe is that it's worse in Oklahoma than it is in other places, just based on the amount of funding that we have here.
But directionally, you're right.
Yeah.
It's not as if you're going to go across the border to Kansas and find that their margins are appreciably or significantly better than ours. I mean, there are certain states and certain communities where they have highly insured populations and big metro populations that are different than ours. Look down to Texas, Dallas-Fort Worth, Houston, San Antonio. They have very robust economies. So those margins in those areas are better. Mm-hmm. But it's not as if Texas as a whole they have better margins, but it's not as if they're knocking it out of the park.
And I'd say rural across the country is probably pretty similar.
All right, and I show a little ignorance here because I've sat through 3 or 4 different presentations now that have mentioned this. I think maybe it's time for me to fully understand it, but you brought up the fact that when Obamacare passed and was implemented, it cut your rates. Can you give some more detail on that? I keep hearing it at a very high level, but can you explain better, I guess, what happened and why it happened inside Obamacare, which was supposed to be saving us all from ourselves? It's actually apparently has hurt our hospitals. Is that?
Go ahead.
Yeah, I mean, our Medicare funding, the way we get paid was reduced about 4 or 5% in overall Medicare payments for hospitals. And I think there's some variation based on DRG mix, meaning we get paid by diagnosis category. So it could differ by hospital, but yeah, we gave up a material chunk of Medicare dollars to fund the ACA.
So if you're wanting specifics, we could probably pull some things for you, but Medicare funding is so complicated in so many buckets that, there's a lot of different things that equal those broad numbers that allow us to try to paint the picture simply.
So it's 4 or 5%. So Medicare rates were cut as part of Obamacare 4 or 5%. So basically, there was a rebalancing that went on there on the federal government trying to lower some of the expenses in Medicare with the assumption that you guys would make up the money that you just lost through Medicaid. So somewhat federal government was shifting money from one pot to another.
They were.
But you were still supposed to get the same amount of money in the end. Is that an accurate?
I think that's what we expected as an industry. Again, I think we can get the OHA to give us what the Oklahoma impact was versus OU Medicine's impact. I mean, you've got $250 million in Medicare funding for OU Medicine and services provided. So 3, 4, 5% is a material chunk of money.
Yeah, I would imagine. Okay, so it really should not have been, and I know I keep beating this, I just want to make sure I've got it right in my head. It should not have been a decrease to the hospital systems if we would have been, all in on the program. Really, the expectation originally was that we would not be given the option to opt out.
Correct.
And so if we would not have been given the option to opt out of Medicaid, then that 5% cut would not have hit you at all.
Right, and I think going back to Jay's slide about the margin reduction, if you look at that time period, it's a time period where the state was also cutting Medicaid rates. Mm-hmm. So we had a kind of a double whammy.
Very true.
And we do appreciate the state going back and addressing those rates, as Senator David mentioned, but in 2010 to 2000, we're still not back to where we were in 2010 from a Medicaid perspective, compounded by the Medicare reduction.
Okay. I'll shift to a question that will make me wildly unpopular, but it's one that I hear a lot, and that when you show the list of hospitals that have closed, the argument, and it was one of the very first things said, is free market. We can't have a hospital where people don't live. Mm-hmm. We can't have nursing homes where people don't live. And so is some of this hospital closure, which is something that scares us all to death, and as a guy who had one of his 3 hospitals close, I'll probably get crucified for asking this question, but market forces determine where hospitals should exist. Mm-hmm. And is it fair to say that some of the hospitals that have closed or may close in the future are not due to anything the federal or the state government has done? It's more about where people have chosen to live.
I think it depends on how much you value access points. That's where that slide where I talked about what it takes to create a robust local system and what size can you actually do that with, and can you take advantage of the different Medicare programs that can help with, there's actually another one called a low volume program, I think was actually the words, that you can apply for. So that what you're suggesting is certainly something we should all be considering. But to the people that live in those smaller areas that need the access to care, it's a matter of what type. And we talk a lot about, are there ways to repurpose and to redo some of these hospitals? I'd say almost every system, none of us would probably want to live anywhere that doesn't have 24/7 access to at least urgent care, if not emergent care services. So yeah, how we do it was certainly up for debate, but the necessity of basic primary care probably throughout our society, I would say, is definitely something we need to encourage.
Hospital rates for Medicare are higher than an office rate. And so sometimes those hospital rates will allow the investment to be made in rural community for urgent or emergent care. When you take those hospital rates away, the economies of providing any type of care go away. But I think your point, I think we've got to be willing to talk about the right level of care that's available across the state. And we got to talk about how we can leverage telemedicine. I know Dr. Shrum talked about that. But access in some form or fashion has to be better distributed across the state.
And I think Senator Hayes touched on this, and I kind of want to try to drive there a little more pointedly, maybe. Dr. Shrum, one of her slides, and I've seen it in multiple places now, that 20% of healthcare is actually about what we would term healthcare. Or 20% of health, not healthcare. 20% of health is actually about doctors and hospitals and health care. The rest of it is something totally different. So assuming that the state of Oklahoma can find the $120 million that we would need for our share of Medicaid expansion, and that's a lot of money in a budget that doesn't have a lot of extra money. Why does it make sense to spend all of that money on this little 20% piece of the pie and not on the other 80% piece of that pie? Does that question make sense?
Certainly.
I think it makes sense. I think we've struggled as a country to figure out the right investments to make to affect poor living habits. It's a little harder to target those investments. I think that right now, Eastern Oklahoma City, going back to my point about a grocery store, the only grocery store that services this part of the city closed. And there will be another one that opens, but how do we channel investments to make sure we have healthy food options for people? Certainly ought to be on the table. How do we take the overall economic lift from accepting federal dollars to make some of those investments that actually pay off? I think it's really hard, but it's something that should be considered. You want to make an investment that has an ROI. You don't want to make one that doesn't work. So, but your point's well taken.
One more. Uno mas. Well, maybe. It may roll into 3 or 4 more. Just first off, and especially Mr. Spicer, you seem to indicate that the idea of value-based care, of moving not from fee-to-service but to pay for outcomes, is the right direction to go. Is that a fair summary of your attitude there?
I think paying for what you do, but how you also do it, if that's a way to say it. I think physicians want to do that. They want to do the right thing for the patient. We found as we've had capacity challenges at OU the last 7 or 8 years, we want patients to have access to a bed. We don't want patients tying up a bed if they don't need to be there. So tying value in and moving down that value path is something I know the medical community wants to do, and I think the hospitals understand that it's the right thing for patients.
Okay. I didn't mean to exclude you if you have some thoughts there also.
Well, there's certainly, I think our industry is moving as a whole towards value payments. I think that pretty much Medicare is retooling all their payment systems that direction. I don't think there's any escaping it. I think in most cases it makes sense, but I don't think in all cases it makes sense, depending on the populations you're caring for. If you look at healthcare across the continuum of primary, secondary, tertiary care, when you look at there's different things you can do in different levels of that to have a better competitive model, and then there's some things that it's harder to have a competitive model. But in the end, I think the value payments make a lot of sense because we're trying to do exactly what you're discussing with that. It's why I showed that slide. How do we take these payments and make sure that we're actually improving the health of Americans? I think that's ultimately the goal.
how you apply value for the right episode of care. It's different for heart care than it is for trauma care, right? Or neonatal ICU care. How do you apply value in the behavioral health world? I mean, we've got a huge behavioral health problem in the state and in the country. How do you really get value there when you don't have enough providers and the way we pay for behavioral health is broken? It is a fee for service, but it's very highly restrictive. If any of you have ever had to navigate the behavioral health world with a family member, it is devastating because they will tell you, we'll pay for 5 days of acute and then you're out. How do you get value with that? Is that really how you pay? So I think it's how you apply value to the right episode of care.
All right, now last but not least. That was just the lead in. Oklahomans in this building and out of this building, in my mind, we have three options in front of us. One is to continue to not expand Medicaid. And then after that, you've got kind of two different ways to go about this. We have, Mr. Johnson's talked a lot about an Oklahoma plan, creating an Oklahoma plan, really going in and creating something that makes sense for our state. Or we also have a ballot initiative that puts into the state constitution the federal system of Medicaid and specifically says that we cannot make alterations to that federal system. So since you guys have very clearly in favor of going in that direction, can you get value-based care if all you do is bring in the federal model and don't allow the state of Oklahoma to actually tailor that down to a different way of doing it, which is a backdoor way of saying, does it really make sense to put Medicaid into the state constitution and tie our hands where we can't make it value-based?
I'm going to assume, because I don't know the exact answer to that question, that since the state still controls the Medicaid program, that there's still some level of value care that you'd be able to do within the system. Whether or not you can apply that to the 9-to-1 match, I don't know the answer to that question, but I would think that the federal government's given the states some control over the Medicaid program to do some of these things, so I would think it's not an all or nothing.
Pro Tem Wright.
Thank you very much, Mr. Chairman. I appreciate that. Thank you for being here. I appreciate your candid remarks and your concerns about Oklahoma's health. I've heard the percentage, but could you give me kind of an update on what percentage of the current population is participating in Medicaid that's eligible under the current circumstances?
The percentage of the Oklahoma population?
Yeah, no, not the Oklahoma population, but of those who are eligible for the current Sooner Care program. What percentage of those are participating?
Yeah, I'd have to find that data point. I don't know that.
I've heard 70 to 80% are participating. There's somewhere around 20% that may not be. Could that be? Does that sound close to correct?
You know, for OU Medicine, you know, every kid that comes in is going to get certified for Medicaid when they're there. Same thing with a mom. So that population, which is 90+% of the patients we take care of, are taking advantage of the Medicare coverage that's out there. There may be some of the adult care that's provided other places that's not, but for OU Medicine, I think we have a process to make sure those folks get onto Medicaid if they need to be on Medicaid.
Follow up? So would you agree, though, that there's a percentage of the current population out there that's eligible for Medicaid that's not participating and taking advantage of it?
I can't agree to something I haven't seen, but I acknowledge that it's possible.
Follow up? So your example of the lady who came in for care for the delivery, you mentioned that she'd not had, I think you mentioned that one.
Right.
That she'd not had any prenatal care, but she would have been eligible for Medicaid.
She would have been eligible for Medicaid.
So
the issue was probably access to physician. It wasn't eligibility for Medicaid. A doctor that would see family, where there was the representative over from Eastern Oklahoma. You don't have a doctor that will take a Medicaid patient in their office. Even if you're eligible, you don't have access to care.
So I guess the question I would have that ultimately would relate to the additional coverage, if we're not able to reach the people that a certain percentage, how is increasing the Medicaid, expanding Medicaid going to help in that area?
Well, I think that was hopefully something I tried to do a good job of getting across it. Accepting the federal dollars won't do anything if you don't improve access. But you won't improve access. I don't see any way in the short term to do that without finding those dollars federally to reinvest in those access points. And it may have a way to re-attract providers to rural communities because they'll have less uncompensated care. But certainly there's an obligation on all of us to work together on that access issue. If we just accept the dollars and don't expand access, our outcomes aren't going to change.
Follow up. So what I'm finding in talking to my physicians, at least some that take Medicaid, is that they're talking about limiting their practice, plus some doctors that are experienced and have been in business for a period of time are discontinuing their Medicaid practice. I know in one of my communities, they work together to take Medicaid. They kind of discontinued that. So it seems like we have, in addition to the financial aspect of this, we have a real problem in what they're getting paid and in terms of reimbursements for Medicaid patients. Would you agree with that?
Yeah, and it's Medicare too. I probably have a twice a month occurrence of somebody that moves their mom or dad to Oklahoma City and they can't get a primary care doctor to accept another Medicare patient. So it's Medicare and Medicaid. It's the youngest and it's the oldest part of our population.
Thank you.
There's nobody else in the queue other than me. So it's almost over. I know you may have felt like you're a couple of piñatas. You know, my main concern is, you know, you talk about expansion of Medicare and we just get the same result because there's not commensurate reforms that go with it. And the cost of care just keeps increasing. I'm reading a book right now called The Price We Pay. And it talks about the game that goes on between hospitals, you know, charge master list, whatever, where private insurance companies, they want a steeper discount. And so you guys ratchet up your price to get the margin that you need. And it just keeps going like this. And it's just a game that keeps playing. So my question is, do you acknowledge that game happens? And what can be done to stop it?
Well, I think it's more than rate that affects whatever the game. A part of it is a bit free market. You get, you know, our costs are going up too. The costs of drugs are going up. The cost of labor is going up. Not only is the cost of labor going up because of the workforce shortage, the workforce for training doesn't work specifically with physicians. Don't provide the same level of hour, you know, the number of hours in a week that we had 20 years ago. So the cost of care are going up. So that affects the game. I would encourage that hospitals have to make money because we're heavily capital intensive. Price an MRI machine, not cheap. You can't go buy it at Best Buy. They're very expensive. So I question the capital intensity and the reason for the high margins to some of the insurance companies, but that's a different discussion. But can the game be better played? Sure. I think we've had 2 good negotiations this year with 2 major insurance companies that have gone ultimately very well for both. And I think we've had reasonable agreements on where pricing sat at the end of those. But we have to look at pricing relative to our costs. And I think Jay's in the same position. Our costs are hard to control.
Thank you for that answer. You know, I mean, I think our goal here as this group is we're trying to do what's right for Oklahomans. We're not trying to do what's right for hospitals, although hospitals are really important to most of our districts if we have one, because it's usually one of the leading economic drivers in our districts. But, you know, you talk about an infusion of federal funds and the cost of healthcare is just so darn high. And I don't know if anybody in this room is comfortable with an infusion of federal funds until we can figure out how in the heck do we stymie or slow down the rising cost of healthcare. And I mean, you've mentioned value-based methods for doing that. I think the jury's still out whether they actually control costs or not. I don't know. The more I get into this, I don't get more confused, but just I see how much more complex it is. I was actually talking to Jay on the phone last night and said, man, this is like a really big onion. And so all I'm wanting from hospitals and providers is is transparency. I mean, and all of that. And I'm just wondering if the hospitals are ready, cost transparency is a federal hot thing right now. There's a hospital in Oklahoma that uses it. I'm wondering if that's where you see healthcare going, and if that alone can help control costs.
You want to take it?
Well,
I'll add.
I'll go and then let Jay go. And so let me give you an example of a value-based program we're doing with Medicare. It's a bundled payment program that pays us for the entire episode of care, not just the inpatient admission, but where the patient goes after the hospital, skilled nursing, rehab, home health. And we have to make the decisions on the care that patient is in, and we're at risk for that. And if the care is higher, we pay a penalty. If the care is better, we get a reward. And that will work in some elements of Medicaid, not all, but that elements like that readmission is a good example of making sure we don't just discharge a patient quickly. We discharge them at the right time so they don't get readmitted in 2 weeks. And Medicaid's again paying again for pneumonia admission. So there's some examples. I think back to the comment about transparency. If I'm a surgery center in North Oklahoma, I don't take Medicare and Medicaid or unfunded patients, I don't do a 78-year-old hip with comorbidity, I can be transparent all day with my cost and my pricing. But we don't have that luxury at OU Medicine. We take everyone, irrespective of their health status, their ability to pay, or their, obviously some of the sickest patients the sickest patients in the state are at OU Medicine. Our case mix index is above 2. 1 is normal. It's above 2. So we have some sick people.
It's similar in rural. I mean, both of our examples are things where you just, the cost structure that we're facing, just you can't change easily. Because really what you're asking is to pay less if we can represent that our margins are 2 to 4%, which they are, when good years they are. This year we will not make that, or at least our last fiscal year. However, we generally do most years. But short of that, you're looking at paying providers less and getting the cost structure in line. And so what costs can we affect? The pharmacy costs are incrementally rising. All of you experience that. Device manufacturers' costs are we don't have a lot of leverage to negotiate those prices. Of course, the price for people tend to go up year over year. So it's really complicated what creates our cost structures and makes it keep rising, and why the payment side is so important so we can keep up with it. That's why this element of what we're buying with the 9-to-1 match is a reduction in uninsured. What we're buying is when someone comes to our ER, we'll get paid. In Duncan, every 4th patient that comes in our ER doesn't pay us anything. Well, that's a huge load. And so those costs, there's no way to really affect the cost of the doctor is the same. The cost of what it costs to hire a board-certified ER doctor in rural Oklahoma has gone up dramatically in the last 10 years, almost double in the last 10 years. In addition to the nurse practitioners that we pay to be there, in addition to the nurses and other staff that are there. And that's just the ER. We could go through every department and come and give examples of the challenges of the expense. That's why we're talking about the revenue, though, is because that expense challenge is so difficult.
Well, thank you both for taking time out of your day. I know that you had to reschedule some stuff. I know some of you are missing board meetings. Really appreciate you being here and sharing the hospital from a rural and urban perspective. Members, we appreciate you being here as well, and the guests who are also in the room. Thank you for coming. At this point, we are adjourned.